Welcome to Nightshift Horror. Before we check in tonight, don't forget to like, subscribe, and let me know where you're tuning in from. Now get comfortable. The night shift is about to begin.
Story 1. Lights dimmed at 23 hours. The chart recorded my observation at 2302, 2 minutes after I noticed the pattern, but 4 minutes before I decided to document it myself. I was admitted to St. Catherine's Medical Center on a Tuesday evening in late October. The diagnosis was straightforward: suspected viral myocarditis requiring 72 hours of cardiac monitoring. Nothing dramatic. Nothing that suggested I would spend the next 3 nights watching my room transform into something I still cannot adequately explain. My room was on the 4th floor, east wing, designated as 4E12. Standard semi-private configuration, though I was the sole occupant. The bed nearest the window was mine. The second bed remained empty, stripped to its plastic mattress cover, which reflected the hallway light in a way that made it look perpetually damp. The nursing staff conducted their evening rounds with practiced efficiency. Vitals at 1800 hours. Medication administration at 1930. Dietary delivered a meal I barely touched. Baked chicken, green beans softened to near liquid, a roll that tasted like compressed air. By 2100 hours, the floor had quieted considerably. Visiting hours concluded at 2000 hours, and the absence of conversation created a vacuum filled by mechanical sounds. The ventilation system's rhythmic breathing, the distant ping of elevator arrivals, the medication cart's squeaking wheel making its 2 jing rounds. I was awake when it happened the first time. At precisely 2300 hours, the overhead fluorescence dimmed, not gradually, the way residential lights fade on a dimmer switch, but in a single coordinated step. Full brightness to approximately 30% illumination in less than a second. The transition was so uniform, so synchronized, that I initially assumed it was automated. Hospitals operate on schedules. Lighting adjustments to promote patient rest made logical sense. What disturbed me was the absence of announcement. No intercom notification, no nursing staff checking to ensure patients were comfortable with the change. Just darkness arriving like a predetermined event, indifferent to whether anyone was prepared. I pressed the call button. The indicator light activated. A small red beacon above my bed, but no corresponding voice emerged from the speaker asking how they could help. I waited 4 minutes. Then 7. At 12 minutes, I pressed it again. The nurse who eventually arrived was someone I had not seen during the day shift. Her badge identified her as R. Whitlock, RN. She entered without knocking, her expression professionally neutral. "Is there something you need?" she asked. "The lights," I said. "They went out suddenly. I wanted to make sure everything was all right." She glanced at the ceiling as though confirming the lights were in fact dimmed. "That's the standard nighttime setting. Activates at 2300 hours. No one mentioned it earlier. It's documented in the admission materials." She gestured vaguely toward the folder clipped to the foot of my bed, which I had not yet read thoroughly. "Is there anything else?" "No," I said, "thank you." She left without further comment. The door settled closed with a pneumatic hiss, sealing me back into the reduced light. I retrieved the admission folder. 12 pages of standard hospital documentation. Consent forms. HIPAA notifications, patient rights and responsibilities. I read each page carefully. Nowhere did I find reference to automatic lighting adjustments or nighttime protocols. The second night I prepared for it. I had requested a notepad from the day shift nurse claiming I wanted to journal as part of stress management. She provided a pocket-sized spiral notebook and a pen with the hospital logo. At 22:45, I positioned myself upright in bed, pen ready, eyes on the digital clock mounted opposite my bed. 22:58. The hallway maintained its low murmur. Distant voices, the soft beep of monitoring equipment from neighboring rooms. 22:59. I watched the second hand on the clock sweep through its final rotation. 2300 hours. The lights dimmed. Exact same reduction. Same instantaneous transition. But this time, I noticed something else. The monitoring equipment attached to me, the pulse oximeter on my finger, the telemetry leads on my chest, registered a brief fluctuation. The screen flickered just for a fraction of a second, and the numerical displays refreshed. My heart rate, which had been steady at 68 beats per minute, now read 71. Blood oxygen saturation unchanged at 98%. Blood pressure displayed identically to the reading taken 30 minutes prior. I wrote this down. Lights dim 23-hour equipment flicker. HR change 6871. At 2304 the door opened. Not the pneumatic settling of someone pushing it from the hallway, but an independent opening, as though the door had decided on its own to reveal Nurse Whitlock standing in the threshold. "Just checking your vitals," she said, approaching with a handheld device. "Someone was just here at 22:30, I said. "Standard protocol," she replied, scanning the barcode on my wristband. The device beeped. She glanced at the screen, made a notation on a tablet, and left. I checked my notebook. I had written the time as 2304. When I looked at my bedside chart, the physical paper record mounted in a clear plastic sleeve near the door, the most recent vital signs entry was timestamped 2302, 2 minutes before I had decided to document the lights, 4 minutes before Nurse Whitlock entered. The third night, I tried to stay ahead of it. At 22:30, I began writing observations. I described the room in detail. The precise position of the IV pole, the angle of the visitor's chair, the number of ceiling tiles I could count from my bed. 37 full tiles, 4 partial. I noted the sounds currently audible. A television from the room to my left playing what sounded like a late-night talk show. A conversation between staff members near the nursing station discussing weekend plans. The environmental services cart being wheeled past my door. At 22:55, I wrote, "Waiting for 23 on lighting change. We'll document everything that happens." 2300 hours arrived. The lights dimmed. I began writing. Lights dimmed exactly 23 odds. No announcement. Monitoring equipment. I stopped. The notebook page already contained text below what I had just written. In my handwriting, in the same pen, was a continuation. Experienced brief flicker. Heart rate adjusted from 68 to 71 BPM. Nurse Whitlock will arrive at 23:04 to check vitals. She will scan my wristband and leave without speaking beyond protocol confirmation. I stared at the words. I had not written them. I was staring at the page, pen hovering, watching the ink dry on text I did not remember producing. The monitoring equipment flickered. Heart rate changed from 68 to 71. I looked at the clock. 2301. At 2304, the door opened independently. Nurse Whitlock entered, scanned my wristband, checked her tablet, and departed without additional comment. I turned the notebook page. The next page contained a full paragraph in my handwriting. "You will think you are observing the pattern. You are not observing. You are confirming what has already been documented. The chart at the foot of your bed contains tonight's vital signs through 0600 hours tomorrow. Your discharge summary was written before your admission. The lights dim at 23U, not to help you sleep, but to mark the transition between what you believe is happening and what is being recorded as having happened." My hands were shaking. I stood, pulling the IV pole with me, and crossed to the foot of the bed. The chart was there, clipped securely in its plastic holder. I flipped it open. 6 pages of documentation. Vital signs recorded at 2-hour intervals through the night. nursing notes describing my sleep quality, my cooperation with overnight assessments, my stable cardiac rhythm throughout the monitoring period. All time-stamped, all signed. The date on the top of each page was 3 days ahead of the current date. I was reading documentation of nights that had not yet occurred. I returned to the bed, pulling the blanket around my shoulders despite the room's controlled temperature. The television in the next room had gone silent. The hallway conversations had ceased. The only sound was the ventilation system and my own breathing, which seemed too loud, too irregular, like I was hearing it recorded and played back with a slight delay. At 0100 hours, the lights dimmed further. Another coordinated step down to what I estimated was 10% illumination. Just enough to see outlines, shadows, the red glow of the monitoring equipment. No one entered to check on me. At 0300 hours, another reduction. The room became a collection of geometric absences. Darker shapes against dark backgrounds. I could no longer see the second bed clearly, only its outline and the reflection of something that might have been light or might have been my imagination insisting on pattern where none existed. The monitoring equipment continued its steady documentation. Heart rate, blood pressure, oxygen saturation. Each measurement recorded, time-stamped, signed by nursing staff who may or may not have physically entered the room. At 0500 hours, I heard the medication cart approaching. The squeaking wheel announced its progress down the hallway, stopping at each room. I listened to it grow closer. 4E8, 4E9, 4E10, 4E11. The squeaking stopped outside my door. No one entered. After approximately 90 seconds, the squeaking resumed, continuing past my room to 4E13. I checked my chart. Medication administration was documented at 0503 hours. Cardiac medication, oral, taken without difficulty, no adverse reaction noted. I had received no medication. At 0600 hours, the lights returned to full brightness. The transition was as immediate as the dimming. A single coordinated step from darkness to institutional fluorescence that burned my adjusted eyes and made me raise my hand to shield my face. The day shift arrived at 0700 hours. A different nurse, badge identifying her as M. Brennan, RN, entered with practiced cheerfulness that felt like an assault after the night's silence. "Good morning. How did you sleep?" "I didn't," I said. She consulted her tablet, scrolling through overnight notes. "Records show you had a restful night. Vitals remain stable. No incidents reported." I was awake the entire time. She made a notation on the tablet. "I'll document that you're reporting poor sleep quality. We can discuss options with the physician during rounds." "The lights," I said. "Why do they dim like that?" "Like what?" "At 2300 hours, and again at 010305. She looked at me with an expression I could not interpret. Not quite confusion, not quite concern. Something adjacent to recognition. "The lights operate on a standard hospital schedule," she said carefully. "They're designed to promote rest. They documented medications I didn't receive. I'm sure there's been no error." She smiled, professional and impenetrable. "Let me get the day physician to speak with you." She left. I was discharged that afternoon. The cardiologist reviewed my monitoring results. All normal, no significant arrhythmias detected, viral markers declining appropriately, and cleared me to continue recovery at home with oral medications and a follow-up appointment in 2 weeks. The discharge paperwork was dated 3 days earlier. I signed it anyway. At home, I reviewed the notebook I had been allowed to keep. Most pages contained my observations written in my handwriting, describing events I remembered documenting. But interspersed throughout were paragraphs I did not recall writing. Observations made in past tense about things that had not yet happened when the ink touched paper. One entry dated the night before my admission read, "The lights will dim at 23:00. You will notice this and believe you are discovering something. You are not discovering. You are participating in documentation that preceded your arrival. When they tell you that you slept, they are reading what was written. When you insist you remained awake, you are confirming what needed to be confirmed. Some observations are made before the observer arrives. Some charts close before the patient is admitted. I keep the notebook in my desk drawer now. I have not opened it in 6 weeks. But sometimes late at night when I am trying to sleep, I think about the lights in my bedroom. How they are controlled by a switch I operate manually. How they dim or brighten at my discretion. How no one documents the precise moment I choose darkness. And then I wonder if that is true, or if somewhere there is a chart that already knows. Story 2. Bed assignment error. They moved me to a bed that already had my name on it, which should have been impossible because I had only arrived 7 minutes earlier. I came through the emergency department on a Friday night in mid-November. The complaint was kidney stones, confirmed by CT scan, pain managed with IV medication. Urologist consulted and recommended observation until passage. Standard protocol. Nothing about my case suggested complexity. The ER attending explained that all inpatient beds were occupied, but they had overflow capacity in a transitional unit on the 3rd floor. I would remain there until a standard medical surgical bed became available, likely by morning. They estimated 4 to 6 hours. I agreed. The alternative was going home to manage the pain alone, and the medication was only effective intravenously. At 22:15, transport arrived with a wheelchair. The transporter, a young man whose badge identified him as K. Matthews, was polite but distracted, checking his phone between navigating hallways. We took the service elevator to avoid the main traffic routes. The 3rd floor was quiet, dimly lit, with a different acoustic quality than the ER. Sound seemed to stop short rather than echo. The overflow unit consisted of 6 rooms arranged along a single corridor. Each door was labeled with a number and letter combination, 3TA through 3TF. Transport wheeled me to 3TC, 3rd door on the left. He opened the door, helped me transfer from wheelchair to bed, and handed me a call button clipped to the bed rail. "Nurse will be by shortly," he said, and left before I could ask any questions. The room was small, clearly designed for temporary use. 1 bed, 1 chair, 1 narrow window showing the parking lot 3 floors below. No bathroom. The transporter had mentioned a shared facility at the corridor's end. A whiteboard on the wall across from the bed displayed standard information fields. Nurse name, physician, pain goal, expected discharge. In the expected discharge field, someone had written, "Pending bed availability." In the patient name field, at the top of the board, Jason Holder. My name is Jason Holder. I stared at the whiteboard. The handwriting was utilitarian, the kind produced quickly during shift routines. But the board should have been blank. I had just arrived. No nursing staff had entered the room yet. I considered pressing the call button, then decided I was reading too much into standard preparation. Perhaps transport had radioed ahead. Perhaps someone had updated the board while I was in transit. Hospitals operated on information systems designed for efficiency. Pre-populated fields made sense. The nurse arrived at 22:38. Her badge read L. Kovich, RN. She verified my identity using my wristband, checked the IV site in my left forearm, and asked about my current pain level. 4 out of 10, I said. Manageable. She made a notation on a tablet. We'll continue the fluids and monitor for stone passage. If your pain increases, press the call button. I'll be back at midnight to reassess. How long have I been assigned to this bed? I asked. She glanced up from the tablet, expression polite but puzzled. You were transferred from the ER approximately 20 minutes ago. The board has my name already. Yes, she said, as though this explained everything. We update the boards when patients are assigned. But I just got here. Right. You were assigned to 3TC at 2153 per the bed management system. The board was updated accordingly. I wasn't even in the ER at 2153. I arrived at 2140. She consulted her tablet, scrolling through what I assumed were intake records. System shows your ER registration at 2012 hours. That's not possible. I came in around 2130. She made another notation. I'll check with admissions. Sometimes the timestamps auto-populate incorrectly during high-volume periods. Nothing to worry about. Try to rest. She left. I looked at the whiteboard again. My name spelled correctly in handwriting that was confident and routine. I took out my phone and checked the time. I had texted my brother to let him know I was at the hospital. 2136. 44 minutes ago. Well after the alleged ER registration at 2012. At 0045, Nurse Kovich returned with a different demeanor, still professional but slightly more careful in her word choices. There's been a bed assignment update, she said. We need to move you to 3TE. Why? System reallocated the rooms for better patient flow distribution. It's just 2 doors down. I'll help you get settled. I had already established a minimal territory in 3TC, phone charger plugged in, shoes positioned beside the chair, jacket draped over the seat back. I gathered these items while Nurse Kovich disconnected my IV from the wall pump and switched it to a portable battery pack. The transition required less than 5 minutes. 3TE was identical in layout to 3TC. Same narrow window, same shared bathroom arrangement, same austere functionality. But when I entered, the whiteboard already displayed information. Nurse name, L. Kovich physician, Dr. Raymond Hurst. Pain, goal, less than 410 expected discharge pending bed availability. Patient name, Jason Holder. Who updated this? I asked. Nurse Kovich glanced at the board while reconnecting my IV to the wall pump. Standard practice. The system pushes updates to the boards electronically. The system knows my pain goal. It auto-populates based on general protocols. We individualize as needed. She finished securing the IV line and adjusted the flow rate. Try to get some rest. I'll check on you at 0200. After she left, I examined the whiteboard more closely. The handwriting looked identical to the board in 3TC. Same slant, same pressure, same efficient abbreviation style. But Nurse Kovich had not touched the board. She had not even looked at it beyond a confirming glance. I sat on the edge of the bed and opened my phone's note application. I typed, moved from 3TC to 3TE at 0045. Both boards pre-populated with my name and information. Nurse claims electronic system, but handwriting appears identical. At 0137, Nurse Kovich returned. Another adjustment, she said, and this time her tone contained a trace of apology. We need to move you to 3TF. You're joking. I understand it's disruptive. The bed management system is reallocating based on incoming transfers. 3TF will be your final placement tonight. This is the 3rd room in 3 hours. I know. I'm sorry. Hospital capacity management sometimes requires flexibility. I gathered my belongings again, phone charger, shoes, jacket, and followed her 2 doors down to 3TF, the last room at the corridor's end. The transition was becoming routine. Disconnect IV, switch to portable pump, transfer patient, reconnect to wall pump. Nurse Kovich performed the sequence with practiced efficiency. 3TF matched the previous rooms in every functional detail. But the whiteboard displayed not just my information, but a full history. Patient name, Jason Holder, admit date, November 11th, ER registration 2012, room assignment. History, 3TC 2153 on 045, 3TE 045 on 0137, 3TF 0137, present. I stared at the timeline. The room transitions were documented in past tense with precise timestamps for moves that had been explained as spontaneous system reallocations. This was planned, I said. Nurse Kovacs looked at the board, then at me. The system optimizes bed assignments continuously. It's algorithmic, not planned by individual staff. But someone knew I would be moved 3 times. The system generates predictions based on incoming patient volume and expected discharge times. Sometimes those predictions inform pre-positioning. She spoke carefully, as though reading from a script she had been provided for this specific conversation. I want to speak to a supervisor. I'll send a message to the night supervisor. She's currently responding to a situation on the 5th floor, but should be available within the hour. Nurse Kovacs completed the IV reconnection. Is your pain controlled? Yes. Good. I'll be back at 0300. She left. I photographed the whiteboard with my phone, capturing the complete timeline. Then I opened my admission paperwork, the packet they had given me in the ER, which I had folded into my jacket pocket. The top page displayed standard demographic verification, name, date of birth, insurance information, emergency contact. At the bottom of the page, in small print, ER registration 2012. But I had not arrived until after 21:30. I checked my phone again, scrolling back through my text messages. The message to my brother, heading to ER, kidney stone, will update later, was time-stamped 21:24. 6 minutes before I actually walked through the emergency department entrance. I had not sent that message at 21:24. I remembered sending it from the ER waiting area after I had already been triaged and was waiting for a CT scan. That had been around 2200 hours, but my phone insisted otherwise. At 0300 hours, Nurse Kovacs returned for vitals check. Blood pressure, temperature, pulse oximetry, all routine measurements that she recorded on her tablet without comment. When was I registered in the ER? I asked. Your chart indicates 2012 hours. I wasn't there at 2012. She looked at me with the same careful expression she had used earlier. Electronic records are time-stamped automatically when registration is completed. There's no manual adjustment. Then the system is wrong. I'll note your concern. She made a notation on the tablet. The night supervisor should be available shortly. Has anyone else been assigned to these rooms tonight? Before me? She paused mid-notation. What do you mean? 3TC, 3TE, 3TF. Was I the first patient assigned to each room tonight? Yes, she said after a moment. The unit was empty prior to your arrival. Then how were the boards already filled out? Electronic pre-population. I've explained this. Handwriting isn't electronic. Mr. Holder, I need to continue my rounds. The supervisor will address your concerns. She finished her notation and left before I could respond. I stood and walked to the door, looking out into the corridor. The overhead lights were dimmed for nighttime hours, creating pools of shadow between each doorway. The other 5 rooms, 3TA through 3TE, had their doors closed. No light emanated from beneath any of them. No sounds suggested occupancy. I walked to 3TE 2 doors back and tried the handle. The door was locked. I continued to 3TD, 3TC, all locked. Only 3TF remained accessible. I returned to my room and sat on the bed, pulling the blanket around my shoulders. The kidney stone pain had subsided to a background ache, manageable without thinking about it unless I focused attention there. But a different discomfort had taken its place, a sense of misalignment, like the night was proceeding on a track parallel to my experience of it. At 04:53, a woman in business casual attire entered without knocking. Her badge identified her as R. Simmons, night supervisor. Mr. Holder, I understand you've had concerns about your room assignments tonight. I've been moved 3 times. The documentation doesn't match my timeline. And the rooms were already labeled with my information before I arrived. She consulted a tablet, identical to the one Nurse Kovich carried. I see you were initially placed in 3TC at 21:53, then reallocated based on system optimization protocols. This is standard during high census periods. I wasn't even here at 21:53. Your ER registration was completed at 2012 hours, which initiated the bed assignment process. Sometimes there's a lag between registration and physical transport, but the system operates from the registration timestamp. That timestamp is wrong. I have text messages proving I wasn't here until after 21:30. She looked at the tablet screen, scrolling through what I assumed were my medical records. Mr. Holder, electronic documentation systems are highly reliable. Manual recollection of specific times, especially during painful episodes, can be less precise. I assure you the system has accurately tracked your care. Can I see the registration record? The actual entry showing when I checked in. That information is part of your medical record, which you can request copies of through Health Information Management. The process typically takes 3 to 5 business days. I'm asking to see it now. I don't have authorization to provide real-time record access beyond clinical necessity. Her tone remained professional but had hardened slightly, the way voices do when boundaries are being enforced. Is there anything else you need for your comfort tonight? I need to understand why the rooms were already prepared for me. The rooms are prepared through electronic protocols designed to improve efficiency and reduce patient wait times. This is beneficial for your care. How does the system know where to move me before deciding to move me? She smiled, a practiced expression that acknowledged the question without engaging its implications. Predictive algorithms analyze bed utilization patterns and incoming patient volume to optimize placement. It's quite sophisticated. Now, unless there's a clinical concern, I need to continue my supervisory rounds. She left. I did not sleep. I sat upright in the bed, watching the window as the parking lot lights created geometric patterns on the glass. At 0600 hours, the overhead lights returned to full brightness, and the corridor outside resumed a daytime acoustic quality. Voices, footsteps, the distant ring of telephones. At 0720, Nurse Kovich returned. Good morning. How are you feeling? The same. Any stone passage overnight? No. We'll continue monitoring. The day shift physician will round at 0900. She checked the IV, made notations on her tablet, and started to leave. What happens to the boards when patients leave? I asked. She turned back. Sorry? The whiteboards. Do you erase them or does the system reset them? We erase them manually during room turnover. Can I see the other rooms? 3TA through 3TE? Those rooms are currently unoccupied and locked for cleaning protocols. They've been empty all night. Why do they need cleaning? Standard procedure between uses. She offered a polite smile. I'll be back later to check on you. At 0845, a medical surgical bed became available on the 5th floor. Transport arrived to move me again, this time with a different transporter who did not make conversation. I was wheeled to 5 West 22, a standard patient room with a bathroom and a roommate separated by a privacy curtain. The whiteboard in 5 West 22 was blank when I arrived. The day nurse introduced herself, verified my identity, and wrote her name on the board. K. Patterson, RN. She did not write my name. She did not document my arrival time. She left the patient name field empty. I was discharged that evening after confirming stone passage. The urologist reviewed follow-up instructions and handed me prescriptions for pain management and preventive medication. The discharge paperwork listed my total length of stay as 48 hours. I had been in the hospital for less than 22 hours. When I questioned this, the discharge nurse, someone I had not met before, consulted her computer and said, "System shows admission on November 11th at 2012. Today is November 13th. That calculates to 48 hours. Today is November 12th, I said. She looked at me, then at her computer screen, then at the calendar on the wall behind her desk. November 13th. I checked my phone. November 13th. I had lost a day somewhere between the ER and discharge. Or the system had gained one. The mathematics no longer aligned with my linear experience of time, and no one seemed troubled by the discrepancy. I signed the discharge paperwork. I accepted the prescriptions. I took the elevator to the ground floor and walked to my car in the parking lot, which was exactly where I had left it. Except the parking ticket on my dashboard was dated November 11th, 2 days earlier, time-stamped 2012. Story 3. Vitals taken while sleeping. I was awake for every single check, but the chart insisted I slept through all of them. The surgery had been minor. Arthroscopic repair of a torn meniscus in my left knee. Outpatient procedure extended to overnight observation due to persistent nausea after anesthesia. The surgeon assured me this was precautionary, that I would be discharged by morning once the anti-nausea medication stabilized my system. I was admitted to the post-anesthesia care unit at 14:30 on a Wednesday in early December and transferred to a standard recovery room on the second floor by 1700 hours. My name is Catherine Vance. I am 34 years old, employed as a regulatory compliance analyst for a pharmaceutical documentation firm. My work involves reviewing clinical trial data for consistency and accuracy, which means I am accustomed to identifying discrepancies in recorded information. This background is relevant to what I am about to describe. The recovery room was designated 2 South 18, a single occupancy space with a large window facing the hospital's interior courtyard. The nursing staff explained that overnight monitoring would consist of vital signs checks every 4 hours, at 2200 hours, 0200 hours, and 0600 hours, plus assessment of surgical site, pain level, and neurological status. Standard post-operative protocol. Nothing about my case suggested complications. The day shift nurse, a woman named G. Merrick, RN, completed her final check at 19:30. She reviewed pain management options, confirmed I could tolerate liquids without nausea, and explained that the night shift nurse would introduce herself during evening rounds. "Try to get some rest," Nurse Merrick said. "The more you sleep, the better you'll feel in the morning." I intended to follow this advice. I was exhausted from the preoperative fasting, the anesthesia, and the physical stress of surgery. But the room's ambient conditions made sleep difficult. The bed was firm in a way that created pressure points at my hips and shoulders. The surgical dressing on my knee generated a constant low-grade itch I was instructed not to scratch. And the courtyard window, despite the blinds being closed, allowed sound to penetrate, voices from the floors above and below, the mechanical hum of the HVAC system, occasional announcements over the outdoor speakers directing staff to various departments. At 21:45, the night shift nurse entered. Her badge identified her as D. Parrish, RN. She was perhaps 50 years old, with silver hair pulled back in a practical bun and an economy of movement that suggested decades of experience. Evening, Catherine. I'm Dawn. I'll be taking care of you tonight. She scanned my wristband with a handheld device, verified my identity verbally, and consulted a tablet. Pain level? 3 out of 10. Manageable. Good. I'll be back at 2200 to check your vitals. Call if you need anything before then. She left, and I attempted to find a comfortable position. The bed allowed electronic adjustment of the head and foot sections, but no configuration eliminated the pressure points. I settled for a semi-reclined position that distributed my weight slightly more evenly and closed my eyes. At precisely 2200 hours, the door opened. I opened my eyes. Nurse Parrish entered with a blood pressure cuff and digital thermometer. "Sorry to wake you," she said. "I wasn't asleep." "Oh," she seemed mildly surprised. "Well, let's get your vitals." She wrapped the cuff around my right upper arm, pressed the start button, and waited while the device inflated and measured. The digital display showed 118/74. She recorded this on her tablet. Then she scanned my forehead with the thermometer. 98.6 degrees. She counted my pulse manually at my wrist, comparing it to the pulse oximeter clipped to my finger. 72 beats per minute. "Everything looks good," she said. "Pain level still manageable?" "Yes." "Any nausea?" "No." "Perfect. I'll be back at 0200. She disconnected the blood pressure cuff and left. I checked the bedside clock. 22:06. The vitals check had taken 6 minutes. I was fully awake throughout. I remembered every detail, the pressure of the cuff tightening, the cool touch of the thermometer against my forehead, the gentle pressure of her fingers on my wrist counting my pulse. I tried again to sleep. I adjusted the bed angle, repositioned the pillows, and focused on controlled breathing techniques I had learned years ago during a stress management seminar. Inhale 4 counts. Hold 4 counts. Exhale 4 counts. The rhythm was calming, but sleep remained elusive. At 01:53, I was staring at the ceiling tiles, counting the perforations in each panel as a distraction from the knee discomfort, when the door opened. Nurse Parrish entered again with the same equipment. "Let's check those vitals," she said quietly. "I'm awake," I said. "I can see that." She positioned the blood pressure cuff. "Some people have trouble sleeping after anesthesia. It'll pass." The measurement process repeated. Blood pressure 116/73, temperature 98.7, pulse 70 beats per minute. She recorded each value on her tablet. "Still no nausea?" "None." "Pain?" "Same as before. 3 out of 10. "You're doing great. Try to rest. I'll see you at 0600. She left at 0204. I remained awake. The courtyard sounds had diminished. Fewer voices, no announcements. But the HVAC system maintained its constant presence. A white noise that was almost but not quite monotonous enough to induce sleep. I watched the clock digits change. 0215, 0230, 0245. At 0300 hours exactly, I decided to review my medical chart. The hospital used a patient portal system accessible via bedside tablet, and the day nurse had shown me how to log in. I navigated to the nursing notes section and opened the most recent entries. 22 vital signs obtained. Patient sleeping comfortably. BP 11874 T 98.6 degrave P72 R1602 set 98% on room air. Denies pain, nausea, surgical dressing clean, dry, intact, no concerns noted. D. Parrish. RN. I read the entry 3 times, patient sleeping comfortably. I had been awake. I had spoken to Nurse Parrish. I had confirmed my pain level and absence of nausea. She had remarked that I was awake when she entered. I scrolled to the next entry. O2, SIR, vital signs obtained. Patient remains sleeping. BP 11673, T 98.7 degree, P70 R14, O2 sat 98% on room air. No signs of distress. Surgical site stable. Pain management adequate per previous assessment. D. Parish, RN, patient remains sleeping. The vital signs were accurate. The timing was correct. But the clinical observation contradicted my lived experience. I had been awake, alert, conversant. I had watched her perform each measurement. She had acknowledged my wakefulness. I pressed the call button. Approximately 90 seconds later, Nurse Parish entered. "Do you need something?" "I was reading my chart," I said. "The nursing notes say I was sleeping during the vitals checks." She glanced at the bedside tablet, then back at me. "You were resting quietly both times. I tried not to disturb you." "I was awake. We spoke." "Did we?" Her expression was professionally neutral, but something in her tone suggested she was humoring me. Sometimes patients are in a light sleep state and don't realize it. Anesthesia can affect memory formation. "I remember everything. At 2200, you said sorry to wake you, and I told you I wasn't asleep. You measured my blood pressure, temperature, and pulse. You asked about pain and nausea. At 0200, you commented that some people have trouble sleeping after anesthesia." She listened to this recitation without interruption. When I finished, she consulted her tablet, scrolling through what I assumed were her notes. "My documentation reflects what I observed during care. If you were awake, I apologize for the charting error. I'll update the notes. But you wrote that I was sleeping immediately after the checks, both times. I document as I observe. If there's a discrepancy, it's unintentional." She tapped something on the tablet. "I've added an amendment noting that you recall being awake during assessments. Is there anything else you need?" "No. Try to get some rest." She left. I returned to the chart. The nursing notes now showed an addendum. 0215 patient reports being awake during 22's on and 02's on or vital signs checks. Patient states she recalls conversation and assessment details. Noted for continuity of care. Patient alert and oriented X4 at this time. D. Parish, RN. The addendum acknowledged my complaint but did not alter the original entries. The chart still documented that I had been sleeping. The amendment only confirmed that I believed otherwise. I did not attempt to sleep after that. I remained in the semi-reclined position, watching the window blinds for any change in exterior light that would signal approaching dawn. The courtyard remained dark. The clock advanced with mechanical precision. 0330, 0400, 0430. At 0543, I noticed something on the bedside tablet. The screen had dimmed to conserve power, but a notification icon was visible in the upper right corner. I tapped the screen to reactivate it. The notification indicated a new entry in my chart. I opened the nursing notes section. 0400, vital signs obtained. Patient in deep sleep. No spontaneous movement observed. BP 11572 T98.6 degree P68 R12 O2 sat 98% on room air. REM sleep patterns noted. Rapid eye movement visible beneath closed lids, occasional verbal murmuring. Patient appears to be dreaming. Content of speech unclear, but tone suggests processing of daily experiences. Surgical recovery progressing normally, no intervention required. D. Parish, RN. I stared at the entry. 0400 hours, 17 minutes ago. I had been awake, watching the clock, counting the minutes until the scheduled 0600 check. No one had entered the room, no vitals had been taken. And yet the documentation was there, time-stamped and detailed, describing observations that had not occurred. More than that, the entry described me dreaming. It described REM sleep patterns. It described verbal murmuring and content analysis. I pressed the call button and did not release it. The button emitted a continuous chime, an emergency signal distinct from the standard call request. Within 30 seconds, Nurse Parrish entered at a quickened pace. What's wrong? You documented vitals at 0400. Yes. You were sleeping very deeply. I didn't want to disturb you, so I kept the interaction minimal. You didn't enter this room at 0400. Catherine, I understand the anesthesia can... I have been awake continuously since 0200. I have been watching that clock. I pointed at the digital display. I have been counting minutes. No one entered this room at 0400. She looked at the tablet, then at me, and something in her expression shifted. Not concern exactly. More like recognition. What do you remember about the 0400 check? She asked carefully. There was no 0400 check, that's what I'm telling you. Close your eyes for a moment. What? Please. Close your eyes and describe what you remember from 0400 hours. I closed my eyes, humoring what felt like a deflection. I was lying in this bed in this position, watching the clock change from 0359 to 0400. The room looked exactly as it does now. The courtyard was dark. The HVAC system was humming. No one entered. Keep your eyes closed. What happened at 0401? The clock changed to 0401. What were you thinking about? I was thinking about how much longer until the 0600 check. And at 0402? The same thing. I was counting minutes. What happened at 0415? I opened my eyes. I don't remember 0415 specifically. It was the same as all the other minutes. Nurse Parrish consulted her tablet, scrolling through screens I could not see from my angle. Catherine, I need to ask you something, and I need you to answer as honestly as you can. Do you remember dreaming tonight? I haven't slept. Do you remember any gaps in your awareness? Any moments where time seemed to skip? No. She made a notation on the tablet. I'm going to have the charge nurse come speak with you. There's nothing wrong. I just want to get another clinical perspective. On what? On your post-operative recovery. Some patients experience what we call paradoxical wakefulness. They feel alert but are actually transitioning in and out of sleep states without recognizing the transitions. It's related to anesthesia metabolism. I'm not transitioning in and out of sleep, I'm awake. I understand that's how it feels. The charge nurse will be here shortly. She left before I could argue further. I returned to the chart and scrolled back through the night's documentation. 4 entries total, 2200 hours. Patient sleeping comfortably. 0200 hours. Patient remains sleeping. 0400 hours. Patient in deep sleep. REM patterns noted. And a scheduled entry for 0600 hours that had not yet occurred but was already time-stamped in the system as a pending task. I opened the vital signs flowsheet, which displayed measurements in a graphical format. The blood pressure readings showed a gradual decline from 118/74 to 115/72. The pulse rate decreased from 72 to 68. The respiratory rate slowed from 16 breaths per minute to 12. These were the physiological patterns of someone entering deeper stages of sleep. But I had been awake. At 0558, the charge nurse entered. Her badge identified her as P. Ling, RN, MSN. She was younger than Nurse Parrish, perhaps late 30s, with an air of administrative authority. Ms. Vance, I understand you're concerned about the overnight documentation. The notes say I was sleeping. I wasn't. Dawn mentioned you don't recall the 0400 vitals check. Is that correct? There was no 0400 vitals check. She didn't enter the room. Do you recall what you were doing at 0400? I was lying here, awake, watching the clock. Do you remember any specific thoughts you were having, any particular thing you were focusing on? I tried to reconstruct the moment. 0400 hours. What had I been thinking? I remembered watching the clock digits change. I remembered the HVAC hum. I remembered the courtyard darkness, but I did not remember any specific thought. No particular concern or observation, just awareness, the passage of time marked by mechanical systems. I was aware of the room, I said. Were you aware of yourself? The question unsettled me in a way I could not immediately articulate. What do you mean? Were you thinking about yourself? Your body, your position, your physical sensations? I considered this. I was aware of my knee, the discomfort. Constantly or intermittently? I don't know. It was there. She made a note on a tablet identical to the one Nurse Parrish carried. Ms. Vance, I want to show you something. This is a recording from the monitoring equipment in your room. She tapped the screen several times, then turned it toward me. The video showed my room from an overhead angle, grainy but clear enough to identify the bed and window. The timestamp read 0355. On the screen, I lay motionless in the semi-reclined position, eyes closed, breathing with the slow rhythm of sleep. At 0400 exactly, Nurse Parrish entered. She approached the bed, wrapped the blood pressure cuff around my arm, my motionless arm, and activated the device. The cuff inflated. I did not stir. She scanned my forehead with the thermometer. I did not open my eyes. She counted my pulse at my wrist, watching the bedside monitor for correlation. I remained still. At 0404, she made notations on her tablet while standing beside the bed, looking down at me. Then she left. On the video, I did not move. My eyes remained closed. My chest rose and fell with unchanging rhythm. That isn't possible, I said. The camera doesn't malfunction, Nurse Ling said gently. It records continuously. I was awake. You remember being awake. That's not the same thing. I remember everything. I remember thinking about this conversation, about calling you, about the documentation errors. When did you think about calling me? I stopped. When had I decided to press the call button? I remembered pressing it after seeing the 0400 entry. But when had I read that entry? The timestamp said 0543, but I had pressed the call button at... When? I looked at the bedside clock. 0603. The 0600 check, I said. She was supposed to come at 0600. She completed it at 0600. You were sleeping. No. I've been talking to you since 0558. Nurse Ling showed me the tablet again. The video timestamp now read 0600. Nurse Parrish entered the room, performed the vitals check on my sleeping form, documented her findings, and left. On the video, I never woke, but I was awake now. I was speaking to Nurse Ling. I was alert, oriented, and actively protesting, wasn't I? I want to show you one more thing, Nurse Ling said. She navigated to a different section of the chart and opened an attachment labeled Sleep Monitoring Data. The screen displayed a complex graph with multiple colored lines representing different physiological parameters. This is data from your telemetry leads, she explained. They monitor more than just heart rate. They track respiratory patterns, movement, and brain activity through skin conductance and micro-muscle responses. These readings indicate sleep architecture. The graph showed clear progressions through sleep stages: light sleep at 2200 hours, deep sleep at 0200, REM sleep at 0400. The patterns were unmistakable, textbook representations of normal sleep cycles. But at each of these timestamps, Nurse Ling continued, you also generated patterns consistent with wakefulness. Specifically, you showed dream incorporation of external stimuli. When Dawn checked your blood pressure, your sleeping brain wove that sensation into your dream content. You experienced it as a waking interaction, but physiologically you remained asleep. That's not possible. It's rare, but documented. It's called lucid somnambulism, a state where patients dream they are awake and interacting with their environment while remaining physiologically asleep. The dream is vivid enough that memory formation occurs, creating false recollections of wakefulness. I don't believe you. The data doesn't require belief. It documents what occurred. She showed me additional graphs, additional video clips, all confirming the same narrative. I had slept through the night. I had been monitored, assessed, and documented while unconscious. My memories of wakefulness were dream constructs. But I remember this conversation. I remember Nurse Ling's face, her precise diction, the weight of the tablet in her hands. I remember the surgical discomfort in my knee, the pressure points on my hips, the HVAC hum. How can memories this detailed be false? You're going to feel disoriented for a while, Nurse Ling said. The brain doesn't like contradictory information, but you're physiologically recovered and ready for discharge. Dr. Monroe will be by at 0800 to clear you. She left. I was discharged at 0930. The surgeon reviewed the overnight monitoring data, confirmed my vital signs were stable, and provided post-operative instructions. The discharge nurse gave me prescriptions and a follow-up appointment card. When I got home, I reviewed the discharge paperwork. Included in the packet was a summary of overnight nursing notes. All 4 entries documented continuous sleep. All 4 described me as resting comfortably, showing no signs of distress, requiring no intervention. The final entry, documented at 0600 hours, included an additional observation. Patient in REM sleep, verbal murmuring noted. Content suggests patient is dreaming about reading medical charts and speaking with nursing staff about documentation. Dream incorporation of environmental stimuli consistent with processing of hospital experience. Recovery progressing appropriately. I was dreaming about reading the charts that documented I was dreaming. At least that is what the charts insist. But I am awake now. I am certain of that. I am typing this account on my home computer, fully alert, with clear memory of every detail. Or I am dreaming this too, and somewhere a chart is being updated with observations I will never see, written in a language I cannot parse, documenting a version of myself I do not recognize. Story 4. Call button response time. The call button lit up, but no one came, and eventually the system stopped acknowledging I was asking. I was admitted to Presbyterian Medical Center on a Tuesday morning in late January. The complaint was acute diverticulitis requiring IV antibiotics and bowel rest. Standard treatment. 3 to 5 days of observation according to the gastroenterologist who admitted me. Nothing about my case suggested complexity or unusual risk. My name is Brian Holloway. I am 41 years old, employed as a quality assurance supervisor for an automotive parts manufacturer. My job involves testing component failure rates and documenting response protocols. I mention this because it made me particularly attentive to what constitutes acceptable response time and what that metric means when it begins to deteriorate. The room was on the 3rd floor medical surgical unit designated as 3 West 27, semi-private configuration, but I was the sole occupant. The other bed remained empty throughout my stay. A whiteboard on the wall displayed my nurse's name, T. Hutchins, RN. A call button was clipped to the bed rail within easy reach, a gray plastic device with a single red button and a speaker grill. The day shift nurse, the aforementioned T. Hutchins, explained the call system during his orientation. Press the button if you need assistance. It sends an alert to the nursing station and my personal pager. Average response time is about 3 minutes depending on what else is happening on the floor. If it's an emergency, press and hold for 2 seconds. That triggers a rapid response. Understood, I said. "I'll check on you every 2 hours, but don't hesitate to call if you need something between checks." At 14:30, I pressed the call button for the first time. Non-emergency. I needed assistance getting to the bathroom. Hospital policy for patients on IV antibiotics experiencing abdominal pain. The button lit red when pressed. Through the speaker came a brief acknowledgement tone, a single beep confirming signal receipt. I waited. At 14:33, 3 minutes, Nurse Hutchins entered. "What can I help you with?" "Need to use the bathroom." "Let's get you there." He disconnected my IV from the pole, switched it to a portable pump, and assisted me across the room. The process was efficient and professional. At 14:40, I was back in bed, IV reconnected. "That was excellent response time," I said. He smiled. "We try. Call if you need anything else." At 1700 hours, I pressed the button again. I needed water. The pitcher on my bedside table was empty, and I was restricted to ice chips per the bowel rest protocol. The button lit red. The acknowledgement tone sounded. I waited. At 17:04, 4 minutes, a different nurse entered. Her badge identified her as M. Carlson, RN. "You called? I need more ice chips. I'll bring those right away." She left and returned within 2 minutes with a fresh pitcher of ice. "Anything else?" "No, thank you." The shift change occurred at 1900 hours. The night nurse introduced herself as L. Brennan, RN, a woman in her late 20s with efficiency in her movements that suggested competence. She reviewed my care plan, checked my IV site, and confirmed I understood the call button system. "Press if you need anything," she said. "I'm here until 0700. At 21:45, I pressed the button. The abdominal pain had intensified, not emergency level, but enough that I wanted to request additional pain medication within the prescribed parameters. The button lit red. The acknowledgement tone sounded. I waited. At 21:51, 6 minutes, Nurse Brennan entered. "What do you need?" "Pain has increased. Maybe a 6 out of 10 now." She consulted her tablet. "You're due for pain medication at 2200. I can give it a little early. I'll be right back." She returned at 21:55 with oral medication. I took it with water. She documented the administration on her tablet and left. 6 minutes. Acceptable given she had to retrieve medication and document. But the response time was trending upward. At 0030, I pressed the button again. I needed to use the bathroom. The button lit red. The acknowledgement tone sounded. I waited. At 0037, 7 minutes, Nurse Brennan entered. "Bathroom?" "Yes, please." She assisted me across the room, waited outside the bathroom door, and helped me back to bed. At 0043, I was settled again. "Response time is increasing," I said. She paused while reconnecting my IV. "We had an admission in the next room. That takes priority during initial assessment. I came as soon as I could." "I understand, just noting the pattern. If it's an emergency, hold the button for 2 seconds. That gets immediate response." "I know, this wasn't an emergency." She left. At 0200 hours, I pressed the button again. Not for assistance, this was a test. I wanted to measure response time under low-demand conditions in the middle of the night. The button lit red. The acknowledgement tone sounded. I waited. At 0209, 9 minutes, Nurse Brennan entered. "Do you need something?" "Just checking the call system is working." She looked at me with an expression I could not interpret. "The system is functioning normally." It took 9 minutes. I was attending to another patient. Non-emergency calls are prioritized based on clinical need. What determines clinical need for a call you haven't responded to yet? The system categorizes calls algorithmically. Room location, patient acuity, time since last interaction. It's designed to optimize nursing workflow. So the system decided my call was low priority. Your call was addressed within acceptable parameters. Her tone had cooled slightly. Is there something you actually need? No. She left. I lay in the dark. The lights had dimmed at 2300 hours and thought about algorithmic prioritization. In my work, we used similar systems to route quality control alerts. High failure rate components triggered immediate inspection. Low-risk deviations entered a queue for batch review. The system was efficient, but only as good as its categorization logic. What logic determined that 9 minutes was acceptable? At 0400 hours, I pressed the button. This time I needed actual assistance, medication for breakthrough pain. The button lit red. The acknowledgement tone sounded. I waited. At 0412, 12 minutes, Nurse Brennan entered. You called? Pain is back, 7 out of 10. She checked her tablet. You're not due for more pain medication until 0600. Can I have something for breakthrough pain? I'll check with the on-call provider. She left. At 0428, 16 minutes after my initial call, she returned with a different medication. Provider approved a one-time dose of this. It should help. I took the medication. She documented and left. 16 minutes total response time for pain management. I noted this mentally but said nothing. At 0600 hours, I pressed the button for morning vitals. Nurse Brennan had mentioned she would check on me at 0600, but I wanted to test whether calling expedited the process. The button lit red. The acknowledgement tone sounded. I waited. At 0617, 17 minutes, Nurse Brennan entered with the vitals equipment. Morning, let's get your blood pressure. I called at 0600. I was in the middle of medication pass. I came as soon as I finished. 17 minutes. That's within acceptable range for non-urgent calls. She wrapped the blood pressure cuff around my arm and took the measurement in silence. 122/80. Temperature 98.4. Pulse 74. All documented on her tablet. Day shift will be here at 0700. She left. The day shift nurse, a different person this time, badge identifying him as K. Morrison, RN, introduced himself at 0715 and reviewed my overnight progress. I mentioned the increasing call button response times. Nights are staffed differently, he said. Higher patient-to-nurse ratios. Response times can be longer, but that's normal. Is 17 minutes normal? For non-emergency calls, yes. If something is urgent, that's what the rapid response is for. I did not argue. That night, my second night, the pattern continued. I tested the call button at intervals, documenting each response time. 2200 hours call for bathroom assistance. Response at 2219. 19 minutes. 0100 hours call for water refill. Response at 0123, 23 minutes. 0300 hours call for pain medication. Response at 0329. 29 minutes. Each time Nurse Brennan, still on shift, explained she was attending to other patients, completing documentation, or responding to higher priority calls. Each time she emphasized that my requests were non-urgent and within acceptable parameters. But the parameters were expanding. On the third night, I pressed the button at 22:30. I needed to use the bathroom. The button lit red. The acknowledgement tone sounded. I waited. At 2300 hours, 30 minutes, no one had arrived. I pressed the button again. The light remained red. No additional acknowledgement tone. The system interpreted the second press as redundant. At 23:15, I pressed and held for 2 seconds, triggering the rapid response. At 23:17, Nurse Brennan entered at a quickened pace, followed by a second nurse I had not seen before. "What's the emergency?" "I've been waiting 47 minutes for bathroom assistance." "You triggered a rapid response for bathroom assistance?" "I triggered a standard call 47 minutes ago. No one responded." She consulted her tablet, scrolling through what I assumed were call logs. "System shows your call at 22:30 was acknowledged and categorized as low priority based on recent call frequency and clinical assessment." "Clinical assessment of what? You didn't respond." "The system uses predictive algorithms. Your previous calls established a pattern of non-urgent needs. The algorithm adjusted your priority accordingly." "I still need to use the bathroom." "Let's get you there." She helped me across the room, her movements efficient but visibly annoyed. When I was back in bed, she said, "Rapid responses for emergencies, chest pain, difficulty breathing, falls. Using it for routine needs pulls staff away from actual emergencies. Routine needs that go unaddressed for 47 minutes become urgent. The system is designed to balance competing demands. If you feel your needs aren't being met, I can have the charge nurse speak with you in the morning." She left before I could respond. At 0200 hours, I pressed the button. Pain level had increased to 8 out of 10. The button lit red. The acknowledgement tone sounded. I waited. 0230, no response. I pressed the button again. The light remained red. No acknowledgement tone. 0300, no response. I pressed and held for rapid response. No one came. I pressed and held again. The button remained lit, but no rapid response team arrived. No footsteps in the hallway, no voices outside my door. At 0320, I pressed the button repeatedly, 10, 15, 20 times in succession. The light flickered with each press but remained red. No acknowledgement tones, no response. At 0400, the pain had become severe enough that I attempted to get out of bed without assistance. The IV line restricted my movement, but I managed to sit upright and swing my legs over the side of the bed. Standing required more effort. The abdominal pain intensified with position changes. But I reached the bathroom doorway before dizziness forced me to stop. I pressed the call button from the bathroom. The button was also integrated into the bathroom wall unit. It lit red. No acknowledgement tone. I waited in the bathroom doorway, leaning against the frame until 0445, when the dizziness subsided enough to return to bed. At 0600 hours, Nurse Brennan entered for morning vitals. She did not mention the call button. She did not ask if I needed anything. She took my blood pressure, 130/88 elevated, and documented it without comment. "I called multiple times overnight," I said. "I have no record of calls from this room after 0200 hours. I pressed the button at least 30 times between 0200 and 0400. She consulted her tablet. "System log shows one call at 0200 acknowledged and categorized as low priority. No subsequent calls logged." The button was lit. I pressed it repeatedly. "If the system didn't log it, there was a malfunction. I'll report it to maintenance." "What about the rapid response at 0300? "No rapid response was triggered from this room overnight." I held the button for 2 seconds, multiple times. "The system would have logged that. It didn't." She finished the vitals check and left. At 0700, the day shift nurse arrived. I explained the situation again. The increasing response times, the ignored calls, the failed rapid response. He listened politely, then said, "I'll check with the night supervisor about system malfunctions. In the meantime, if you need anything today, I'm right down the hall." "Will the call button work?" "Of course, system tests ran this morning. Everything's functioning normally." At 1400 hours, I pressed the button to test his claim. The button lit red. The acknowledgement tone sounded. No one came. At 14:30, I pressed it again. No acknowledgement tone this time. The light remained red. At 1500, the day nurse entered for scheduled vitals check. "How are you feeling?" I called at 1400. No one responded. He checked his tablet. "I don't show any calls from this room this afternoon." The button lit up. Sometimes the indicator light stays on after a call is resolved. "Did you need something?" I was testing the system. "The system is working fine." He completed the vitals check and left. That night, the fourth night, I did not press the call button. I needed to use the bathroom at 2300 hours, but managed the trip independently, moving carefully to avoid dislodging the IV. At 0200 hours, the pain level increased to 7 out of 10, but I waited until the scheduled 0600 medication time rather than call. At 0600 hours, Nurse Brennan entered for morning vitals. "You didn't call at all last night." "No." "Pain under control?" "It was manageable." She smiled, a professional expression that seemed rehearsed. "See, you're becoming more independent. That's a sign of improvement." She documented something on her tablet. I could not see the screen, but her note-taking lasted longer than usual for a simple vitals check. At 0800, the hospitalist arrived for morning rounds. He reviewed my chart, confirmed the antibiotics were effective, and said I could be discharged that afternoon if I could tolerate a regular diet. "You've made excellent progress," he said. "The nursing notes indicate you've required minimal intervention overnight. That's exactly what we like to see." "The nursing notes are incomplete." "How so?" "They don't reflect the calls that went unanswered." He scrolled through the chart on his tablet. "I see documentation of appropriate response times for the calls that were logged. If you felt response times were inadequate, that's feedback for patient satisfaction surveys, but clinically, your recovery has been appropriate." "What about the calls that weren't logged?" "If calls aren't logged, there's no documentation to review, but again, your clinical progress is what matters, and that's been excellent." I was discharged at 1500 hours. The discharge nurse provided instructions for oral antibiotics, dietary progression, and follow-up appointments. She handed me a patient satisfaction survey. "We value your feedback," she said. "There's a section specifically about call button response times." I completed the survey at home. In the section about call button response, I described the pattern. Response times increasing from 3 minutes to 47 minutes, calls that went unlogged, rapid responses that failed to trigger. The final question asked, "Did you feel your needs were adequately addressed during your stay?" I wrote, "The system determined my needs were adequately addressed before anyone responded to assess what those needs were." I submitted the survey online. The confirmation page thanked me for my participation and indicated my feedback would be reviewed within 10 business days. That was 6 weeks ago. I have received no follow-up contact, but sometimes late at night when I cannot sleep, I think about that call button. How it lit up red each time I pressed it, how the acknowledgement tone confirmed signal receipt, how the system logged my silence as improvement. And I wonder how many other requests are categorized as low priority before anyone evaluates what is being asked. Story 5. Roommate Unlisted. I was admitted to a shared room with no assigned roommate, but the other bed was used every night. My name is Angela Cross. I am 29 years old, employed as a legal assistant specializing in medical malpractice documentation. I was admitted to Valley Regional Hospital on a Thursday evening in mid-February following an emergency appendectomy. The procedure was uncomplicated, laparoscopic removal, standard post-operative protocol. But I developed a post-surgical infection that required extended IV antibiotic treatment. My surgeon estimated a 4 to 5 day stay. The room was on the 4th floor surgical recovery unit designated as 4 South 11. Semi-private configuration, 2 beds separated by a fabric privacy curtain mounted on a ceiling track, 2 windows, 1 bathroom shared between occupants. When I was wheeled in from the recovery area at approximately 1900 hours, the second bed was empty, not just unoccupied, but stripped to its plastic mattress cover, no linens, no pillow. The admitting nurse, a woman named R. Vasquez, RN, oriented me to the room. You'll have the bed nearest the window. The bathroom is shared, but you're the only patient in here right now, so you have it to yourself. Will I be getting a roommate? I asked. Depends on census. We're at moderate capacity tonight. If someone needs the bed, you might. But for now, you've got the space. She reviewed post-operative instructions, confirmed my pain level, 4 out of 10 manageable, and left me to rest. The room was quiet. The 4th floor maintained a different atmosphere than the ER or the pre-op area, slower, more controlled, with sounds that arrived at predictable intervals. Call bells from neighboring rooms, the medication cart's squeaking wheel, the environmental services staff vacuuming the hallway at precise 20-minute intervals. I tried to sleep but found it difficult. The surgical incisions produced a persistent ache despite pain medication. The IV line in my left forearm restricted comfortable positioning, and the empty bed across from me created a visual imbalance, a space defined by absence. At 22:30, I heard the door open. I assumed it was the night nurse conducting rounds, but instead I heard the rustling of fabric and the mechanical adjustment of the second bed, the head section being raised, the side rails being locked into position. I turned my head, expecting to see nursing staff preparing the bed for a new admission. The second bed remained empty. Stripped mattress, no linens. The privacy curtain had not been disturbed. The room appeared exactly as it had when Nurse Vasquez left. But I had heard the sounds clearly. The bed adjustment motor had a distinctive mechanical whir. The side rail locks produced a specific metallic click. I pressed the call button. At 22:37, a nurse I had not met before entered. His badge identified him as J. Keene, RN. Do you need something? Is someone being admitted to the other bed? He glanced at the second bed. Not that I'm aware of. Why? I heard someone preparing it, adjusting the position. He walked to the second bed and examined it briefly. Looks the same as it has all evening. Sometimes sounds carry from other rooms. The walls aren't as thick as they should be. It sounded like it came from inside this room. I'll check the hallway census board. If there's an admission coming, I'll let you know. He left before I could ask anything else. At 2300 hours, the overhead lights dimmed automatically. I had been warned about this by Nurse Vasquez, standard nighttime protocol to promote rest. The reduction in light made the second bed more difficult to see clearly, transforming it into a rectangular shadow against the far wall. At 0100 hours, I woke to the sound of breathing. Not my own breathing, that was shallow and controlled, paced carefully to avoid aggravating the surgical pain. This was deeper, slower, the kind of breathing produced during deep sleep. It was coming from the direction of the second bed. I turned my head. In the dim light, I could not see details, only the outline of the bed and the window beyond it. The breathing continued, rhythmic and undeniable. I pressed the call button. At 0108, Nurse Keene entered. What's wrong? There's someone in the other bed. He looked at the second bed. No, there isn't. I can hear them breathing. He walked to the second bed, close enough to touch it, and looked down at the bare mattress. Room is just you tonight. Maybe you're hearing the ventilation system. The air handler on this floor has a rhythmic cycle that can sound like breathing. I know the difference between HVAC and human breathing. Post-operative medications can affect sensory perception. You might be experiencing auditory distortions. It's not uncommon after anesthesia. I've been awake for hours. The anesthesia has worn off. Still, your system is processing a lot right now. Pain medication, antibiotics, surgical stress. I'll document that you're hearing sounds. If it continues or if you feel unsafe, call again. He left. The breathing continued. I lay in the dark, listening to it, trying to convince myself it was the ventilation system or the building settling or some other explicable source. But the rhythm was too irregular for machinery. It varied slightly. A deeper inhalation here, a pause there, the natural variation of biological respiration. At 0300 hours, the breathing stopped. Not gradually, the way someone transitioning from sleep to wakefulness might alter their breathing pattern. It simply ceased, mid-cycle, as though switched off. The silence that followed was absolute. No ventilation hum, no hallway sounds, no distant call bells. Just emptiness that felt heavier than sound. I did not press the call button. I lay awake until 0600 hours when the overhead lights returned to full brightness and the day shift nurse arrived for morning vitals. Her name was P. Donovan, RN. She took my blood pressure, temperature, and pulse while asking about pain level and surgical site comfort. I mentioned the nighttime sounds. Nurse Keene documented that you reported auditory disturbances, she said. How are you feeling this morning? The same. I heard breathing from the other bed. The other bed is unoccupied, has been all night. I know what I heard. I'll mention it to the physician during rounds. Sometimes post-op patients experience sensory phenomena. It's usually temporary. She left. At 0900 hours, the surgeon arrived to check the incision sites. He removed the dressings, examined the wounds, and declared them healing appropriately despite the infection. We'll continue the IV antibiotics. You should be ready for discharge in 2 to 3 days. I'm hearing things at night, I said. Breathing from the empty bed. He glanced at the second bed. Anesthesia and pain medications can produce perceptual effects. They should diminish as the drugs clear your system. If the sounds are preventing sleep, we can adjust your medication. I don't want medication adjusted. I want to understand why I'm hearing breathing from an empty bed. I'll have the nurse note your concerns. For now, focus on recovery. The better you sleep, the faster you heal. He left. That night, the second night, the pattern repeated. At 22:30, I heard the bed adjustment sounds, the motor whir, the side rail clicks. At 0100, the breathing resumed. But this time, at 0200 hours, I heard something else. Movement, the rustling of fabric, as though someone was shifting position beneath blankets. The creak of the bed frame adjusting to redistributed weight. I turned on the bedside lamp. The sudden light burned my adjusted eyes, but I forced them to focus on the second bed. Empty. Stripped mattress. No linens, no pillow, no visible source for the sounds I was hearing. But the sounds continued. Fabric rustling, the bed creaking, and beneath it all, the steady rhythm of breathing. I pressed the call button and did not release it, triggering a continuous chime. At 0203, Nurse Keene entered at a quickened pace. What's the emergency? The bed, someone is in it. He looked at the second bed, illuminated now by both my lamp and the hallway light spilling through the open door. Angela, there's no one there. I can hear them, listen. He stopped moving. The room fell silent. No breathing, no rustling, no creaking, just the ambient hum of the building systems. I don't hear anything, he said. It stops when you enter. When I enter? Yes, every time. It stops when the door opens. He consulted a tablet, scrolling through what I assumed were my medical records. Your pain medication includes a narcotic component that can cause auditory hallucinations. I'm going to contact the on-call physician about adjusting your regimen. I'm not hallucinating. Someone is using that bed. The bed assignment system shows this room as single occupancy tonight. No one has been admitted to 4 South 11 except you. Then check the laundry logs. The what? The laundry logs. If someone is using that bed, there should be linens being changed, housekeeping records. He looked at me for a long moment, expression unreadable. I'll check with environmental services, try to rest. He left, and the sounds resumed immediately. Breathing, rustling, the bed creaking with occupied weight. At 0700 hours, Nurse Donovan returned for morning vitals. I asked her about the laundry logs. What about them? I want to know if linens have been changed on the second bed. The bed is unoccupied. There are no linens to change. Can you check? She consulted her tablet, navigating through screens I could not see. Housekeeping records show What? There's a notation here. Linens replaced on bed B, that's the second bed, at 0630 this morning. Replaced from what? The bed is empty. It says they were soiled, standard protocol for overnight use. But no one is assigned to that bed. No one according to the census system. She looked at the stripped mattress, then back at her tablet. This might be a documentation error. I'll report it to the charge nurse. At 1400 hours, the charge nurse arrived. Her badge identified her as M. Unger, RN BSN. She was in her 50s with an air of administrative authority. Ms. Cross, I understand you have concerns about the second bed. Someone is using it at night. The census system shows no roommate assigned to you. The laundry logs show linens being changed this morning. I reviewed that. It appears to be an error in the housekeeping documentation system. Sometimes room numbers get transposed during data entry. The bed makes sounds at night, adjustment motors, breathing, movement. Old hospital buildings produce a lot of ambient noise. Pipes, ventilation, the bed frames themselves settling. It can be disorienting, especially at night when sensory input is reduced. This isn't ambient noise. She sat in the visitor's chair beside my bed, a deliberate shift to a less authoritative posture. Ms. Cross, I want you to feel safe and comfortable during your recovery. If the room environment is causing distress, we can move you to a different room. We have a single occupancy available on the 3rd floor. I don't want to be moved. I want to understand what's happening. Sometimes understanding isn't possible. Sometimes we have experiences that don't fit easily into documented systems. That doesn't mean the experiences aren't real to the person having them, but it also doesn't mean there's an external source that can be identified and corrected. You're saying I'm imagining it. I'm saying perception is complicated, especially in medical environments where patients are managing pain, medications, and physical stress. Our goal is your recovery. If this room isn't conducive to that, we have alternatives. I'll stay here. Your choice. But if the disturbances continue, please let us know. We want you to heal, and that requires rest. She left. That night, the 3rd night, I did not sleep. I lay awake from 2200 hours onward, watching the second bed, listening for sounds. At 22:30, the bed adjustment sounds began. Motor whir. Side rail clicks. At 0100, the breathing started. Deep, rhythmic, undeniable. At 0200, the movement sounds resumed. Rustling fabric, creaking frame, and at 0300, something new. A voice. Quiet, barely above a whisper, the words indistinct but the tone clear. Someone speaking in their sleep, murmuring fragments of sentences I could not parse. I turned on the bedside lamp. The second bed was occupied, not visibly. The mattress remained bare, no linens, no pillow. But the surface was depressed as though supporting weight. The depression formed a clear outline. Head, torso, legs, the shape of someone lying in a standard sleeping position. I stared at the depression. It did not move, but the breathing continued, emanating from the location where a mouth would be if the invisible person were real. I pressed the call button. At 0307, Nurse Keene entered. "Angela, look at the bed." He looked. "What am I looking at?" "The mattress. It's compressed. Someone is lying there." He walked to the second bed and placed his hand on the mattress, pressing down. "Mattress looks normal to me." "You can't see the depression?" "No. It's right there. Head, body, legs." He pressed different areas of the mattress, testing the surface. "Memory foam can retain impressions temporarily, but this is a standard institutional mattress. It doesn't do that." "Then what am I seeing?" "I don't know. But I think we need to move you to a different room. This environment is clearly affecting your recovery." "I'm not leaving until someone explains this." "Ms. Cross, there's nothing to explain. The bed is empty. The census is clear. You're experiencing perceptual disturbances that, while real to you, don't have an external source we can identify or correct. Staying in this room is preventing you from healing." "Fine. Move me." At 0400 hours, I was transferred to 3 South 8, a single occupancy room with one bed, one window, and no roommate. The transfer required disconnecting my IV, moving my belongings, and reconnecting everything in the new space. Nurse Keene assisted with practiced efficiency. "You'll be more comfortable here," he said. "Will I?" He did not answer. I was discharged 2 days later. The infection had resolved, the incisions were healing appropriately, and the surgeon cleared me for home recovery with oral antibiotics. Before I left, I asked Nurse Donovan, who had remained my day shift nurse despite the room change, about 4 South 11. "Has anyone been admitted to that room since I left?" "Let me check." She consulted her tablet. "No, it's been empty." "What about the laundry logs?" She navigated to a different screen. "Linens have been changed every morning at 0630 for an empty room." "According to this, yes." "And no one finds that strange?" She looked at me with an expression I could not interpret. "Hospitals are full of documentation errors, Angela. Systems log things that don't happen, happens all the time. Or things happen that systems don't log." She did not respond to that. I left Valley Regional Hospital at 1100 hours on a Tuesday morning. My brother picked me up, and during the drive home I told him about the roommate who was not listed, the breathing I heard, the depression in the mattress that only I could see. He listened without interrupting. When I finished, he said, "You think someone died in that bed?" "I think someone is still using it." "Ghosts?" "I don't know what to call it, but the laundry logs don't lie. Someone is there overnight, and every morning the evidence is removed." He did not argue. "I have been home for 3 weeks now. The incisions have healed. The infection is gone. I sleep in my own bed in my own apartment with no roommate and no unexplained sounds. But sometimes, late at night, I think about that second bed, how it was always empty when observed, always used when not. How systems documented what could not be seen. How absence and presence occupied the same space depending on who was watching. And I wonder if the next patient in 4 South 11 is hearing breathing tonight. Story 6. Imaging scheduled at Oro 2:30. My scan was scheduled outside normal hours, and the imaging suite operated without visible staff. My name is Marcus Reed. I am 37 years old, employed as a telecommunications network engineer responsible for maintaining uptime monitoring systems across regional data centers. I was admitted to Grandview Hospital on a Saturday evening in early March, following 3 days of persistent headaches accompanied by visual disturbances. Temporary blind spots in my left peripheral vision that lasted between 5 and 10 minutes before resolving. The emergency department physician ordered a brain MRI to rule out structural causes. The ER attending explained that the imaging department operated on limited hours during weekends. Routine scans were scheduled for 0800 to 1700 hours. My scan, classified as semi-urgent, neurological symptoms requiring evaluation but no immediate life threat, would be scheduled at the next available slot. At 2100 hours, I was transferred from the ER to an inpatient observation bed on the second floor while awaiting the imaging appointment. The admitting nurse, a man named V. Chen RN, confirmed I would remain NPO, nothing by mouth, in case contrast dye was needed. "When will the scan happen?" I asked. He consulted a tablet. "Schedule shows 0230. In the morning? That's an unusual time for imaging. Weekend staffing runs different schedules. Semi-urgent scans get slotted into available technician hours. Someone's working overnight tonight, so that's when you're scheduled. Will I be awake? Transport will come get you. You don't have to do anything except go along." At 2200 hours, the overhead lights dimmed per standard nighttime protocol. I lay in the observation bed, less comfortable than a standard inpatient bed, more utilitarian, designed for short stays, and tried to rest. Sleep was impossible. The headache had diminished to a background pressure, but the anxiety about the scan results kept my mind active. At 0223, the door opened. A transport staff member entered, a young woman whose badge identified her as El Rivera Transport Services. She carried no paperwork, no clipboard, none of the usual documentation I had seen other transport staff carrying throughout the evening. "Marcus Reed?" she asked. "Yes." "MRI, let's go." She positioned a wheelchair beside the bed. I transferred from bed to chair without assistance. My mobility was unaffected by the headaches, and she wheeled me into the hallway. The second floor was dark except for low-intensity emergency lighting along the baseboards. The nursing station was staffed by a single person whose face I could not see clearly from my angle. No other patients were visible. No other staff. Transport wheeled me to the elevator bank. We descended to the basement level where the imaging department was located. The elevator doors opened onto a corridor that looked different from the floors above. Older tile, exposed pipes along the ceiling, fluorescent lights that flickered intermittently. "How long have you worked here?" I asked, trying to establish some conversational normalcy. "While," she said. "Not long, not years, just while." We continued down the corridor. The imaging department entrance was marked by a sign with faded lettering. "Radiology, authorized personnel only." Transport used a badge to unlock the door, and we entered a waiting area furnished with plastic chairs and outdated magazines. No one was at the reception desk. No lights were on except for a single overhead panel near the inner door labeled MRI Suite. Transport wheeled me to that door and stopped. "Someone will be with you. You're not staying." "My part's done." She left without further comment, the outer door closing behind her with a pneumatic hiss. I sat in the wheelchair in the dim waiting area, listening to the ambient hum of the building systems. The MRI suite door remained closed. No window, no way to see inside. A sign on the door warned about metal objects and pacemakers. At 0234, according to the wall clock, the MRI suite door opened. Not pushed from inside, not triggered by motion, it simply unlocked and swung inward, revealing darkness beyond. I waited. No technician emerged, no voice called me in. "Hello?" I said. No response. I stood from the wheelchair, uncertain whether I was supposed to remain seated or enter independently. and approached the doorway. Beyond it was a small anteroom with lockers for personal belongings and a changing area with hospital gowns hanging from hooks. Further in, through another door, I could see the MRI machine itself, a large white cylinder with a narrow bore and a motorized table extending from its center. No technician, no staff. The equipment was powered on, indicator lights glowing, the machine emitting a low-frequency hum, but the room was unoccupied. "Is anyone here?" I called. A voice responded, but not from inside the room. It came from a speaker in the ceiling, distorted slightly by amplification. "Please change into a gown and remove all metal objects. Place belongings in a locker. Then position yourself on the scanning table." The voice was male, professionally neutral, offering no identification or additional instruction. "Where are you?" I asked. "Control room. Please proceed with preparation." I looked around the anteroom. I saw no window into a control room. The walls were solid except for the doors. But hospitals often had observation windows concealed by two-way glass or monitoring equipment in adjacent spaces. I changed into the gown, removed my watch and phone, and placed them in locker number 3. Then I entered the scanning room. The MRI machine dominated the space. The bore was approximately 60 centimeters in diameter, lit from within by pale blue light. The motorized table was positioned partially extended with a head cradle and alignment lasers projecting red crosshairs onto the table surface. "Lie on the table, head in the cradle," the voice instructed through ceiling speakers. I complied. The table was cold against my back. The head cradle was firm, designed to prevent movement. I positioned myself according to the laser guides. "Remain still. Scanning will begin shortly." The table began moving, sliding me into the bore. The space was narrow, my shoulders nearly touched the sides, and the ceiling of the bore was perhaps 15 centimeters from my face. I am not claustrophobic, but the confinement was oppressive. The machine activated. The sound was overwhelming. A rhythmic hammering, a metallic clanging that resonated through the table and into my body. I closed my eyes and focused on breathing steadily. The scan progressed through multiple sequences. Each sequence had a distinct sound pattern: rapid clicking, low-frequency throbbing, high-pitched whining. Between sequences, brief silences allowed the voice to instruct. "Next sequence. Remain still." At some point, I had lost track of time within the bore. I opened my eyes and noticed something unusual. The pale blue light illuminating the bore was not static. It was shifting, creating patterns that moved across the curved white surface, geometric shapes, grids, spirals. The patterns were hypnotic, and I found myself watching them instead of keeping my eyes closed. Then the patterns formed text. I blinked, certain I was misperceiving. But the text remained, projected onto the bore ceiling in sharp, legible letters. "Results uploaded or 2:17. I stared at the text. The current time, according to my estimate, was approximately 0250. The scan had started around 0235, but the text indicated results had been uploaded at 0217. 13 minutes before transport had arrived at my room, 18 minutes before the scan began. The text disappeared, replaced by new patterns. The machine continued its hammering sequences. "Hello?" I said, unsure if the microphone was active. "Do not speak during scanning. Remain still." The results were uploaded before the scan started. "Do not speak. Remain still." How is that possible? The machine's hammering intensified, the sound rising to a near painful volume. The table vibrated, the bore lights flickered. Then silence. The table began withdrawing, sliding me out of the bore. I emerged into the scanning room, expecting to see the technician or some explanation for the text I had seen. The room was empty. "Scanning complete," the voice said through the ceiling speakers. You may dress and return to your room. Transport will arrive shortly. I want to speak to the technician. Transport will arrive shortly. I stood from the table, muscles stiff from prolonged immobility, and returned to the anteroom. I dressed quickly, retrieved my belongings from the locker, and returned to the waiting area. The wheelchair was gone. I checked the time on my phone. 0307. The scan had lasted approximately 32 minutes. But the result upload time I had seen in the bore, 0217, remained impossible. Unless the results had been uploaded before I arrived. Unless the scan was not generating data but confirming data already generated. At 0311, the outer door opened. Transport had returned. Not El Rivera, but a different person, a man whose badge I could not read in the dim light. He was pushing a wheelchair. Marcus Reed? Yes, back to your room. I sat in the wheelchair and he pushed me through the basement corridor, into the elevator, up to the second floor. The journey occurred in silence. When we reached my observation bed, he helped me transfer from chair to bed and left without speaking. At 0600 hours, the lights returned to full brightness, and Nurse Chen arrived for morning assessment. How did the scan go? He asked. It was unusual. The results were uploaded before the scan started. He consulted his tablet. Results are already in the system. That was fast. Radiologist must have been reading overnight. The timestamp says 0217. The scan didn't start until 0235. He scrolled through the report. System shows scan start time 0217. Completion 0249. Total scan time 32 minutes. Standard duration for brain MRI without contrast. I wasn't in the scanner at 0217. Transport didn't even pick me up until 0223. Timestamps can auto-populate incorrectly if the system clock syncs during data entry. Happens sometimes. He did not seem concerned. The important thing is the scan is done and results are available. Physician will review them during morning rounds. Can I see the report? Physician will discuss it with you. At 0830, the hospitalist arrived, a different doctor than the ER attending. A woman whose badge identified her as Dr. L. Moss, Internal Medicine. She carried a tablet and reviewed information while standing at the foot of my bed. Good morning, Mr. Reed. Your MRI results are normal. No structural abnormalities, no masses, no vascular malformations. The headaches and visual disturbances are likely migraine-related. We'll discharge you with a neurology referral for outpatient follow-up. The scan results were uploaded before the scan occurred. She looked up from the tablet. I'm sorry. The timestamp says 0217. I wasn't in the machine until after 0230. Imaging timestamps reflect when data is received by the PACS system, Picture Archiving and Communication System. There's sometimes a delay between scan completion and data upload, or the timestamps can be affected by server processing times. It doesn't impact the clinical interpretation. I saw text inside the machine, projected on the bore ceiling. It said results were uploaded at 0217. The MRI machine doesn't project text. It generates magnetic field gradients and radio frequency pulses. What you saw was likely a reflection or optical illusion caused by the lighting and confined space. It was clear, legible. Mr. Reed, you were in a stressful situation, confined in a narrow space with loud noises and visual stimuli. Perception can be affected. What matters is that the scan was completed successfully and the results are reassuring. You're cleared for discharge. She provided discharge instructions, a prescription for migraine prevention medication, and a referral to outpatient neurology. I was released at 1000 hours. At home, I accessed the patient portal to review my imaging report. The document displayed standard radiological language, sequences performed, technical parameters, anatomical findings. The official interpretation confirmed Dr. Moss's summary. Normal brain MRI, no acute pathology. But at the bottom of the report, in a section labeled Technical Notes, was a single line. Pre-scan probability model applied. Predicted result, normal. Confidence interval, 94%. Scan performed to confirm prediction. I read the line multiple times. Pre-scan probability model. Results predicted before imaging. The scan performed not to discover, but to confirm. I called the hospital's radiology department. The receptionist transferred me to a technician supervisor. I explained what I had seen in the bore, the timestamp discrepancy, the technical note about prediction. "I'm not familiar with that notation," the supervisor said. "Our MRI machines don't have predictive software. They generate images based on magnetic resonance signals from your body. There's no pre-scanning prediction involved. It's in my report." "Can you read me the exact text?" I did. "That's unusual. I'll check with our radiologist. Can I put you on hold?" "Yes." I waited 4 minutes. When she returned, her tone had changed. "Mr. Reed, I spoke with Dr. Kellerman, the radiologist who interpreted your scan. He says that notation is not part of the standard template. It may have been auto-populated from a research protocol template by mistake. It doesn't reflect the actual interpretation process." "What research protocol?" "I don't have details, but Dr. Kellerman assures me your scan was interpreted in the standard manner and the results are accurate. Can I speak to Dr. Kellerman?" "He's not available right now. If you have concerns about your results, I recommend following up with your referring physician or the neurology appointment." She ended the call. "I have been home for 2 weeks now. The headaches have diminished. The visual disturbances have not recurred. The neurology appointment is scheduled for next month, but I cannot stop thinking about that text in the bore. Results uploaded 0217. Before I arrived, before the scan started, before the machine had any data to process. And I wonder how many other tests are performed not to discover what is wrong, but to confirm what the system has already decided." Story 7. Medication cart delay. Night medications arrived late, then early, then not at all, and my signature appeared on records I never touched. My name is Robert Keller. I am 52 years old, employed as a municipal water treatment facility operator responsible for monitoring automated chemical dosing systems and compliance documentation. I was admitted to Riverside Medical Center on a Monday morning in late March following an acute exacerbation of chronic obstructive pulmonary disease. The pulmonologist recommended a 5-day admission for IV corticosteroids, respiratory therapy, and medication regimen optimization. I have managed COPD for 11 years. I am familiar with my medications, their dosing schedules, and their effects. This familiarity is relevant to what follows. The room was on the 3rd floor, pulmonary unit, designated as 3 East 14. Standard single occupancy space. The admitting nurse, a woman named Kay Sullivan, RN, reviewed my home medication list and confirmed the hospital would continue most medications with some modifications to dosing and delivery routes. She explained the medication administration schedule. You'll receive breathing treatments every 4 hours. Oral medications are typically distributed at 0800, 1300, 1700, and 2200 hours. IV medications run continuously or at intervals depending on the drug. Any questions? The timing matches my home routine. Should be fine. Good. If you notice anything unusual with your medications, different pills, different timing, anything, let us know immediately. The first day proceeded without incident. Medications arrived at the stated times. I recognized each pill by sight. a skill developed over years of managing multiple prescriptions. Blue inhaler, white corticosteroid tablet, small yellow potassium supplement, large orange pill for gastric protection. Each medication matched what I took at home. The night shift began at 1900 hours. The night nurse, a man whose badge identified him as D. Hooper, RN, introduced himself during evening rounds. He scanned my wristband with a handheld device, verified my identity verbally, and consulted a tablet. Medications at 2200 tonight. Albuterol nebulizer, prednisone 40 milligrams, potassium chloride 20 milliequivalents, omeprazole 20 milligrams. Sound right? Yes. I'll be back at 2200. At 2200 hours exactly, I heard the medication cart in the hallway. The cart had a distinctive sound, a squeaking wheel and the rattle of medication cups in their drawer compartments. It stopped outside my door. I waited. 2205, no one entered. 2210, still no one. At 2215, I pressed the call button. At 2218, Nurse Hooper entered. The medication cart is outside my door, I said. I can hear it. I'm running a few minutes behind. I'll get to you shortly. It's been 15 minutes. I had to verify a medication order for another patient. I'll be right back. He left. At 2227, he returned with a small plastic cup containing pills and a larger cup with water. I examined the contents. Blue inhaler, white tablet, yellow tablet, orange tablet. Everything correct. I took the medications while he documented on his tablet. Then he prepared the nebulizer, a breathing treatment delivered via a mask that produces medicated mist. I inhaled the treatment for 10 minutes while he attended to other patients. At 2243, he returned to disconnect the nebulizer and document completion. Next medications at 0800. Try to get some rest. The following night, my second night, the pattern changed. At 2145, I heard the medication cart approaching. It stopped outside my door. At 2147, Nurse Hooper entered with medications. Early tonight, I said, trying to stay ahead of schedule. He scanned my wristband and handed me the pill cup. I examined the contents. Blue inhaler, white tablet, yellow tablet, orange tablet. Everything appeared correct. I took the medications. I'll set up your nebulizer treatment in a few minutes, he said. Let me finish the other rooms first. At 2230, he had not returned. I pressed the call button. At 2238, he entered. You called? The nebulizer treatment. You said you'd come back. I already did your treatment at 2150. No, you didn't. You gave me pills and said you'd come back for the nebulizer. He consulted his tablet, scrolling through documentation. My notes show nebulizer administered at 2150, completed at 2200. You tolerated it well. No adverse reactions. I didn't receive any nebulizer treatment tonight. Mr. Keller, I documented it as it happened. Are you feeling all right? Any confusion or dizziness? I feel fine. I'm telling you I didn't receive the treatment. Let me check your oxygen saturation. He clipped a pulse oximeter to my finger. The device displayed 94%. That's consistent with having received the treatment. If you hadn't, your saturation would likely be lower. My saturation at home is typically 94%. It doesn't prove anything. I understand you're concerned, but my documentation reflects the care provided. If you're feeling symptomatic, short of breath, chest tightness, let me know and I can contact the physician about an additional treatment. I'm not symptomatic. I'm telling you the documentation is wrong. I'll note your concern. He made an entry on the tablet and left. I lay in the dark. The lights had dimmed at 2300, trying to reconstruct the evening. Nurse Hooper had entered at 2147 with pills. I had taken them. He had said he would return for the nebulizer. He had not returned. At 22:38, he claimed the treatment had already been completed. Either his memory was faulty, or his documentation was fabricated, or I was experiencing cognitive gaps I was not aware of. The third night, I decided to document everything myself. I requested a notepad from the day shift nurse claiming I wanted to track my symptoms for my pulmonologist. She provided a pocket-sized spiral notebook and a pen. At 21:30, I began writing observations. I noted the time, my current symptoms, mild shortness of breath, no chest pain, and my oxygen saturation per the bedside monitor, 93%. At 21:53, I heard the medication card in the hallway. I wrote, "Med card arrived 21:53. Waiting for nurse." At 22:08, Nurse Hooper entered. I wrote the time in the notebook while he scanned my wristband. "Medications tonight," he said, handing me the pill cup. I examined the contents before taking them. Blue inhaler, white tablet, yellow tablet, orange tablet. I swallowed them and wrote, "Pills taken 22:09. Inhaler, prednisone, potassium, omeprazole. All correct." "I'll do your nebulizer now," Nurse Hooper said. He prepared the device, filled it with albuterol solution, and positioned the mask over my nose and mouth. I inhaled the medicated mist while he documented on his tablet. At 22:24, the treatment concluded. Nurse Hooper disconnected the equipment and left. I wrote, "Nebulizer completed 22:24, treatment received as scheduled." At 0800 the next morning, the day shift nurse arrived with morning medications. She handed me the pill cup and I took the pills without incident. Then she showed me her tablet. "I need you to review last night's medication record and confirm accuracy." She turned the screen toward me. The record displayed $22 medications administered, albuterol inhaler, prednisone 40 mg/h, potassium chloride 20 mg/q, omeprazole 20 mg/h. Patient tolerated without issue, 22:15. Albuterol nebulizer treatment administered. Patient tolerated for full 10-minute duration. No adverse reactions. O2 saturation improved from 93% to 96% post-treatment. At the bottom of the record was a signature line. Patient signature confirming receipt. Below that line was a signature. My signature, in handwriting that looked identical to mine. I had not signed anything the previous night. "I didn't sign this," I said. The nurse looked puzzled. "It's right here, your signature." I never touched the tablet. Nurse Hooper never asked me to sign anything. Electronic signature capture is required for controlled medications and certain high-risk treatments. It's hospital policy. I took pills and received a nebulizer. Nothing was controlled substance. She scrolled through the record. Albuterol is documented as requiring signature confirmation per your care plan. It's noted here that you have a history of medication non-adherence at home, so signature confirmation was added to your protocol. I don't have a history of non-adherence. I've managed these medications for 11 years. It's documented in your admission assessment. Let me find it. She navigated to a different screen and showed me an intake form completed during my admission. Under a section labeled Medication History and Compliance, someone had checked a box. Patient reports occasional missed doses due to forgetfulness. Signature confirmation recommended to ensure adherence during admission. I never said that. I never missed doses. This was completed by the admitting nurse during your intake interview. I remember that conversation. She asked about my medication routine. I said I take everything as prescribed, using a pill organizer to stay on schedule. I never said I missed doses. The documentation says otherwise. I looked at the signature on the medication record. It was mine, or an exact replication. The capital R in Robert had the same looped flourish I had used for decades. The K in Keller had the distinctive angular stem I had developed in high school. But I had not signed it. "I want to speak to a supervisor," I said. At 0900 hours, Amady, the nurse manager, arrived. Her badge identified her as S. Brenner, RN, MSN, nurse manager. She carried a tablet and a printout of my medication records. "Mr. Keller, I understand you have concerns about your medication documentation. My signature appears on records I didn't sign." She reviewed the printout. "Electronic signature capture is performed via touchscreen or stylus. The system timestamps each signature and links it to the specific medication administration event. Your signature was captured at 22:15 last night. I was receiving a nebulizer treatment at 22:15. I didn't touch any screen. The timestamp indicates signature was obtained prior to treatment administration. Nurse Hooper never asked me to sign anything. He gave me pills, I took them, then he prepared the nebulizer. No signature request." She consulted her tablet, scrolling through what I assumed were nursing protocols. "It's possible the signature capture occurred automatically based on wristband scanning. Some of our medication systems have integrated biometric confirmation that registers a signature when identity is verified. Biometric confirmation that forges my handwriting? Not forges, captures. The system may have captured your signature from a previous document, admission paperwork, for example, and applied it to subsequent records for efficiency. Without my knowledge or consent? The consent is embedded in the admission documents you signed initially. There's a section authorizing electronic signature replication for routine care documentation. I want to see that section." She navigated to my admission file and displayed a multi-page consent form. On page 7, in small print under a heading labeled Electronic Documentation and Signatures, was a paragraph. "I authorize Riverside Medical Center to utilize electronic signature technology for routine care documentation, including but not limited to medication administration records, treatment confirmations, and care plan acknowledgments. I understand that my signature may be digitally captured and applied to such documents as evidence of my receipt and acceptance of care provided." I read the paragraph 3 times. The language was broad enough to justify what was happening, my signature being applied to records without my active participation, but vague enough that I had not understood the implication when I signed the admission forms. This doesn't justify forging signatures on records that document care I didn't receive. What care do you believe you didn't receive? 2 nights ago, Nurse Hooper documented a nebulizer treatment that never happened. According to the records, the treatment occurred at 21:50 and you tolerated it well. I'm telling you it didn't happen." She looked at me with the same expression I had seen from Nurse Hooper, a mix of professional patience and underlying skepticism. "Mr. Keller, respiratory patients sometimes experience memory gaps related to oxygen fluctuations or medication effects. It's possible you received care you don't consciously recall. My cognition is fine. I've been documenting everything in a notebook to prove it. May I see the notebook?" I handed it to her. She reviewed my entries, timestamps, observations, medication confirmations. When she reached the entry from the previous night, she stopped. "You wrote that the nebulizer was completed at 22:24. "Yes. The official record says 22:15. The official record is wrong. Or your notebook time is wrong. Did you verify your watch against the room clock?" I had not. I had been using my watch to timestamp entries, assuming it was accurate. She handed the notebook back. "I appreciate that you're trying to stay engaged in your care. That's commendable. But discrepancies in personal notes versus official documentation are common, especially regarding precise timing. The official records are generated by time-stamped systems that don't rely on manual observation. What about the signatures? The signatures are part of the electronic record system. If you're concerned about their application, you can decline electronic signature replication. However, that would require you to manually sign every document, which could delay care delivery. I want to decline it. I'll note that in your chart. Going forward, nursing staff will present the tablet for manual signature on medication administrations. She left. That night, the fourth night, Nurse Hooper arrived at 2200 with medications. He handed me the pill cup, then presented the tablet. I need your signature confirming receipt. I signed the screen with my finger. The signature looked shaky, imprecise, nothing like the fluid version that had appeared on previous records. But it was mine, created by my hand in real time. Nebulizer next, he said. He administered the treatment. At 2214, it concluded. He presented the tablet again. Signature confirming treatment completion. I signed. He left. The following morning, the day shift nurse reviewed my overnight records. You signed manually last night. Yes. Your signatures look different from the ones earlier in your stay. Those weren't really mine. They were generated from your admission signature. Legally, they're considered equivalent. Equivalent isn't identical. For documentation purposes, they serve the same function. I was discharged that afternoon. The pulmonologist reviewed my progress, improved oxygenation, stable respiratory status, and cleared me for home with prescriptions and follow-up appointments. At home, I reviewed the discharge paperwork. Included in the packet was a summary of medication administration records. Every entry from my 5-day stay showed my signature confirming receipt and compliance. The signatures from the first 3 nights were fluid, precise, identical to my natural handwriting. The signatures from the 4th and 5th nights, when I signed manually, were shaky, inconsistent, barely recognizable. Looking at them side by side, the electronic versions looked more authentic than the ones I had actually produced. I called the hospital's Health Information Management Department to request copies of all records showing my signature. The clerk explained there would be a processing fee and a 10-business-day turnaround. I paid the fee. 3 weeks later, I received a disc containing scanned images of every document I had signed during admission, 83 pages total. Medication records, treatment confirmations, care plan acknowledgments, dietary selections, therapy schedules. Every page displayed my signature. I remember signing 6 documents: the admission consent form, 2 manual signatures on the 4th night's medication records, and 3 discharge instruction confirmations. The other 77 signatures were applied without my knowledge. I compared them to samples of my genuine signature from checks, legal documents, work forms. The electronically applied signatures were indistinguishable from the authentic ones. In some cases, they looked more consistent than my actual handwriting, which varies slightly depending on fatigue, pen quality, and writing surface. The hospital had created a version of my signature that was more perfect than the original. And somewhere in their systems, that perfected signature continues to confirm care I may or may not have received, creating records that are legally binding and clinically definitive regardless of what I remember experiencing. Story 8. Temperature Regulation Protocol. The room temperature changed every night at set intervals, and the protocol referenced my name as its origin. My name is Jennifer Wade. I am 46 years old, employed as a chemical process documentation specialist for an industrial manufacturing firm. I was admitted to Mercy General Hospital on a Thursday afternoon in mid-April following an acute allergic reaction requiring IV antihistamines and corticosteroids. The allergist recommended 72-hour observation in an isolation room due to the severity of the reaction and the need to identify the allergen source while minimizing environmental triggers. The isolation room was on the 5th floor Allergy and Immunology Unit, designated as 5 North 6. Single occupancy, negative pressure ventilation to prevent external allergen introduction, restricted visitor access. The admitting nurse, a woman named T. Oliver, RN, explained the environmental controls. The room maintains specific temperature and humidity parameters to minimize allergic response triggers. Temperature is set at 22 degrees Celsius, humidity at 40%. If you feel uncomfortable, let us know and we can make adjustments within clinical parameters. 22 degrees is comfortable, I said. Good. We'll monitor your response to treatment and environmental conditions. Call if you need anything. The first afternoon proceeded without incident. The IV medications reduced the facial swelling and respiratory tightness that had brought me to the ER. By 1800 hours, I felt significantly improved. The day shift nurse checked my vitals at regular intervals, each time confirming that temperature and humidity levels remained stable. At 1900 hours, the night shift nurse introduced herself. Her badge identified her as N. Reyes, RN. She reviewed my care plan and confirmed the environmental settings. Room should stay consistent overnight. If you notice any changes in temperature or if you feel uncomfortable, press the call button. Will it get colder at night? Not unless you request it. The environmental system maintains set parameters automatically. At 2300 hours, the overhead lights dimmed per standard protocol. I attempted to sleep, but the events of the day, sudden allergic reaction, emergency department rush, admission to an isolation room, kept my mind active. I lay awake, listening to the negative pressure ventilation system pulling air from the room with a steady whooshing sound. At 0100 hours, I noticed the temperature change. It was subtle at first, a coolness on my exposed arms, a slight chill that made me pull the blanket higher. I checked the digital thermostat mounted on the wall near the door. The display showed 20 degrees Celsius, 2 degrees lower than the stated setting. I pressed the call button. At 0106, Nurse Reyes entered. The temperature dropped, I said. She glanced at the thermostat. Showing 20 degrees, that's within acceptable range for overnight comfort. You said it would stay at 22. The environmental system adjusts based on circadian protocols. Slight temperature reduction during sleep hours can improve rest quality. It's automatic. How much will it drop? Shouldn't go below 19 degrees. If you're cold, I can bring an extra blanket. I'd prefer the temperature stay consistent. I'll note your preference, but the system operates on protocols designed by our environmental medicine team. The adjustments are evidence-based for allergy patients. She left. I tried to sleep, but the temperature continued to decline. By 0200 hours, the thermostat displayed 18 degrees Celsius, 4 degrees below the initial setting. The room felt cold enough that I could see my breath in the dim light, a faint mist that dissipated quickly but unmistakably. I pressed the call button again. At 0209, Nurse Reyes entered. It's 18 degrees now. She checked the thermostat. System is following the overnight protocol. Temperature will stabilize soon. You said it wouldn't go below 19. That's the typical lower limit. Sometimes there's variation based on individual patient parameters. What parameters? Metabolic rate, body surface area, baseline temperature regulation. The system calibrates to each patient. I'm cold. Can you override the protocol? I can request an override, but environmental protocols require physician approval for modification. I'll contact the on-call physician. At 0230, she returned. Physician reviewed your case and recommends continuing the current protocol. The temperature reduction is designed to minimize inflammatory response during sleep. It's actually beneficial for your condition. How is being cold beneficial? Mild hypothermic effect reduces histamine release and inflammatory mediators. It's a standard approach for severe allergic reactions. No one mentioned this during admission. It's part of the isolation room protocol. Patients aren't always briefed on every environmental detail unless they ask. She left. By 0300 hours, the thermostat displayed 17 degrees Celsius. I was shivering despite 2 blankets. My fingers felt numb. The tip of my nose ached from cold exposure. I stood from the bed. The floor was shockingly cold against my bare feet, and approached the thermostat. The digital display showed not only the current temperature, but also a graph indicating temperature progression throughout the night. 2300 hours, 22 degrees 0 100 hours, 20 degrees 0 200 hours, 18 degrees 0 300 hours, 17 degrees 0 400 hours, 16 degrees projected. 0 500 hours, 15 degrees projected. 0 600 hours returned to 22 degrees. The graph was pre-programmed. The temperature decline was not a malfunction or calibration issue. It was an intentional scheduled reduction. Below the graph was a label, Protocol, Wade Circadian Thermal Regulation version 2.4. I stared at the label, Wade, my last name. I pressed the call button and held it, triggering continuous chime. At 0305, Nurse Reyes entered at a quickened pace. What's wrong? The protocol, it has my name on it. She looked at the thermostat display. That's the protocol designation. It's named after the principal investigator who developed it. My name is Wade. Dr. Mitchell Wade. He's a researcher in our environmental medicine department. The protocol is named after him. Show me documentation. I want to see who Dr. Mitchell Wade is. She consulted her tablet, scrolling through screens. I don't have access to research staff directories on this device. But the protocol is well established. It's been in use for 3 years. I was admitted yesterday. How was the protocol version updated to 2.4 before I arrived? Version numbers reflect iterative refinement, not individual patient application. Then why does it say Wade when my name is Wade? That's coincidence. The protocol applies to all patients in isolation rooms with severe allergic reactions. I want to speak to a supervisor. It's 0300 hours. The night supervisor is managing an emergency on another floor. Then I want the temperature turned up now, or I'm leaving against medical advice. She looked at me with an expression that contained both professional concern and something else, something that resembled resignation. Let me contact the environmental systems technician. They may be able to override remotely. She left. At 0320, the door opened again, but instead of Nurse Reyes, a man in hospital maintenance uniform entered. His badge identified him as L. Preston, Environmental Systems. Evening, Ms. Wade. Nurse says you're concerned about the temperature protocol. It's too cold. The thermostat says it's going to drop to 15 degrees by 0500 hours. He approached the thermostat and examined it. System is operating normally. Protocol Wade Circadian Thermal Regulation is active. Why is my name on the protocol? Protocol isn't named after you, it's named after the researcher who designed it. Dr. Mitchell Wade, Environmental Medicine Research Division. Can I speak to Dr. Wade? He's not on site overnight. Research staff operate during day hours. Can you override the protocol? I can, but it requires documentation of medical necessity and physician approval. Without that, overriding could be flagged as a safety event. I'm requesting it. Isn't that medical necessity? Patient comfort preference doesn't meet the threshold for protocol override. Medical necessity means the protocol is causing harm or impeding treatment. I'm shivering. My fingers are numb. How is that not harm? Those are expected physiological responses to therapeutic hypothermia. The protocol is designed to induce mild discomfort to achieve anti-inflammatory effect. I didn't consent to therapeutic hypothermia. Consent is embedded in the admission documents. Environmental protocols for isolation rooms are detailed in Section 12 of the consent form. I had signed the admission forms without reading every section. Section 12 could have said anything. Can you at least show me the protocol documentation? I want to see who Dr. Mitchell Wade is. He consulted a tablet he had brought with him, navigating through system menus. Protocol documentation is restricted to clinical staff. I can generate a summary report, but full protocol details require Research Ethics Board approval for release. A summary is fine. He tapped the screen several times, then showed me the display. Protocol, Wade Circadian Thermal Regulation, version 2.4. Principal Investigator Dr. M. Wade, Environmental Medicine Research Division. Objective, evaluate efficacy of controlled overnight hypothermia in reducing acute allergic inflammatory response in isolated adult patients. Implementation date, April 17th, current date. Enrollment, status, active current patient, Jennifer Wade. DOB, my date of birth. Admit date, current date. I read the implementation date, today. The protocol had been implemented today, the day of my admission. This protocol was activated today. How can it be version 2.4 if it just started? Version numbers reflect development stages prior to clinical implementation. The protocol underwent 2 years of simulation and animal studies before human application. I'm the first human patient. The system indicates active enrollment, which means you're participating in the current study cohort. I didn't agree to participate in a study. Research participation consent is included in the admission documents, Section 15. I want to withdraw from the study. Withdrawal requires completion of a formal request form, review by the Research Ethics Board, and clearance from your attending physician. That process typically takes 48 to 72 hours. I'll be discharged before then, possibly. But while you're admitted to an isolation room, the environmental protocols remain active unless overridden by medical necessity. He left. I sat on the edge of the bed shivering and tried to process what I had just learned. I was enrolled in a research study I had not knowingly consented to. The study protocol bore my last name, either coincidentally or deliberately. The temperature in my room would continue declining to 15 degrees Celsius unless I could prove medical harm. At 0400 hours, the thermostat displayed 16 degrees. I wrapped both blankets around my shoulders and sat upright in bed, too cold to lie down. My teeth chattered. My hands trembled. At 0500 hours, 15 degrees, the coldest point. The room felt like a walk-in refrigerator. I could see my breath continuously now. Not just intermittent mist, but steady vapor plumes with each exhalation. At 0530, the temperature began rising. 16 degrees, then 17. By 0600 hours, when the overhead lights returned to full brightness, the thermostat showed 22 degrees, back to the initial setting. The day shift nurse arrived at 0700. Her badge identified her as M. Larkin, RN. She checked my vitals without mentioning the overnight temperature protocol. How did you sleep? I didn't. It was too cold. Your temperature is slightly below normal, 35.8 Celsius. That's expected with the overnight protocol. It should normalize within an hour or two. I want to speak to Dr. Wade. Your attending physician is Dr. Carson. I'll let him know you want to speak with him during rounds. Not Dr. Carson. Dr. Mitchell Wade, the researcher who designed the temperature protocol. She looked at me with an expression I could not interpret. I'm not familiar with that name. Let me check the staff directory. She consulted her tablet, searching through what I assumed was a hospital personnel database. After several minutes, she looked up. I don't find a Dr. Mitchell Wade in our system. Are you sure that's the correct name? The environmental systems technician told me that's who designed the protocol. Let me contact environmental services and clarify. She left. At 0800 hours, she returned. I spoke with environmental services. They don't have record of a technician named L. Preston, and they're not aware of any protocol called Wade Circadian Thermal Regulation. It's on the thermostat. I can show you. She walked to the thermostat and examined the display. The screen showed only the current temperature, 22 degrees, and basic controls. No graph, no protocol label. I don't see anything except the standard temperature display. It was there overnight. It showed a graph and a protocol name. The thermostat has different display modes. Maybe you saw a diagnostic screen. It showed my name, Wade, and it showed Dr. Mitchell Wade as the principal investigator. Ms. Wade, I think you may have experienced some confusion during the night. Temperature discomfort and sleep disruption can affect perception and memory. I'm not confused. The protocol documentation listed me as the current patient with today's date as the implementation date. She made notes on her tablet. I'll document your concerns and have Dr. Carson discuss them during rounds. At 0900 hours, Dr. Carson arrived, a man in his early 50s with a professional but hurried demeanor. He reviewed my chart while standing at the foot of the bed. Good morning, Ms. Wade. Your inflammatory markers are improving. How are you feeling? The room was 15 degrees last night. Someone enrolled me in a research study without my knowledge. He looked up from the chart. 15 degrees. That would be well below our environmental protocols. The isolation rooms maintain between 20 and 22 degrees. The thermostat showed a programmed decline. It reached 15 degrees at 0500 hours. Let me check the environmental logs. He consulted his tablet, navigating to what appeared to be facility management data. Room 5 North 6 maintained 22 degrees throughout the night. No fluctuations recorded. The thermostat display showed 17, 16, 15 degrees at different times. The thermostat may have been displaying Fahrenheit instead of Celsius. 17 Celsius is about 63 Fahrenheit. Cool but not dangerously cold. I know the difference between Celsius and Fahrenheit. It was Celsius. Your core temperature this morning is 35.8 Celsius. That's mildly hypothermic, which wouldn't occur unless the room temperature had indeed dropped significantly. He paused, considering. However, your body temperature could be reduced from the corticosteroids suppressing your metabolic rate. That's a known side effect. What about the research protocol? The environmental technician confirmed I'm enrolled in a study. I have no record of you being enrolled in any research study. Your admission is for standard clinical care. The protocol was called Wade Circadian Thermal Regulation, version 2.4. Wade is your last name. The technician said it was named after the principal investigator, Dr. Mitchell Wade. We don't have a Dr. Mitchell Wade on staff. I checked with the research office this morning after the night nurse mentioned your concerns. Then who designed the protocol? There is no such protocol in our hospital system. I stared at him, trying to reconcile the detailed information I had been given overnight with his assertion that none of it existed. Can you review the surveillance video from the hallway? The environmental technician entered my room at 0320. His badge said, L. Preston. I'll request a review, but that will take time to process through security. For now, let's focus on your medical care. Your allergy symptoms are improving. If you tolerate oral medications today, we can likely discharge you tomorrow. He left. That night, the second night, I did not sleep. I watched the thermostat continuously from 2300 hours onward. The display remained fixed at 22 degrees Celsius. No graph appeared, no protocol label. The temperature did not change, but I was cold. Not as cold as the previous night, but colder than 22 degrees should feel. I requested an extra blanket from Nurse Reyes. She brought one without comment. At 0300 hours, I stood from the bed and placed my hand against the wall near the thermostat. The surface was cold, noticeably colder than room temperature should produce. I placed my hand against the window glass. Also cold, but less so than the wall. The walls were being cooled independently of the air temperature. I pressed the call button. At 0308, Nurse Reyes entered. The walls are cold. She touched the wall near where I had placed my hand. Feels normal to me. Compare it to the window. She touched both surfaces. They feel about the same. The wall is colder. Ms. Wade, are you feeling all right? You seem very focused on the temperature. Because the temperature is being manipulated. The thermostat shows 22 degrees. That's the set point. The thermostat is lying. She looked at me with concern that felt clinical rather than empathetic. I'm going to contact Dr. Carson. You're exhibiting signs of anxiety and hypervigilance that may indicate a reaction to your medications. I'm not anxious, I'm observant. I'll be right back. At 0330, Dr. Carson arrived. Unusual for a physician to respond to a patient call in the middle of the night unless the situation was urgent. Ms. Wade, Nurse Reyes is concerned about your mental state. My mental state is fine. The room temperature is being controlled in a way that doesn't match the thermostat display. What evidence do you have for that? The walls are cold. My body temperature is below normal. I experienced detailed conversations with an environmental technician who supposedly doesn't exist. All of that can be explained by medication effects and sleep deprivation. Or it can be explained by me being enrolled in a study that you're denying exists. He sat in the visitor's chair beside my bed, a gesture suggesting he was preparing for a longer conversation. Ms. Wade, let me be direct. There is no Dr. Mitchell Wade. There is no Wade circadian thermal regulation protocol. There is no research study. The environmental technician you described doesn't exist in our staffing records. And the surveillance video from last night shows no one entering your room except Nurse Reyes during her documented visits. Then I hallucinated 6 separate interactions with people who don't exist, while simultaneously experiencing physical hypothermia that matches the hallucinated protocol. Corticosteroids can produce vivid dreams and altered perception, especially when combined with antihistamines and sleep disruption. You may have experienced a prolonged hypnagogic state, a semi-conscious condition where dreams feel real and incorporate environmental stimuli. I wasn't asleep. You may not remember sleeping, that's part of the phenomenon. What about my low body temperature? Corticosteroids suppress metabolism, that's documented. And the cold walls? Subjective perception influenced by your belief that the room is being cooled. He stood from the chair. I'm going to order a psychiatric consultation for this morning, not because I think you're mentally ill, but because I want to ensure your medication regimen isn't producing adverse psychological effects. I was discharged that afternoon before the psychiatric consultation occurred. My allergy symptoms had resolved sufficiently for outpatient management. Dr. Carson provided prescriptions and follow-up instructions, and I was released at 1400 hours. At home, I requested copies of my medical records through the patient portal. The documents arrived digitally 3 days later. I reviewed every page. There was no mention of temperature protocols, no documentation of overnight hypothermia, no record of my complaints about cold exposure. The overnight nursing notes described me as resting comfortably during the hours I had been shivering and unable to sleep. But in the discharge summary, under a section labeled Incidental Findings, was a single line. Patient exhibited hypervigilance regarding environmental conditions. Consider baseline anxiety screening at follow-up. They documented my observation as pathology, and somewhere filed in a system I cannot access there